Madam Vice President has an urgent matter to take care of, so she won't be able to join us today, this morning, but she does send her regrets. We will begin our program at 8:30. Uh, However, there's going to be a short activity before we start our official program this morning. We'll start that in a couple of minutes. Thank you. Ali klemutulol ngitrar adal tilgara rik lemarabay nutang el mesoyis be kada ditilgi be momura program. Asking everybody that are still at the back room and outside to please make their way in. We will start today shortly. Thank you. Once again, good morning, everybody. Thank you. Welcome to day two of the Health Summit. Thank you for being here. Again, the Vice President, Madam Vice President, sends her regrets for not being able to make it today to be with us. Something urgent came up and she's not able to join us. So we are going to start with our first presenter. Ariel Buyum is the Executive Director for the Pacific Islands Primary Care Association, commonly known as PIPCA. Are you okay? And she will give us a talk about improving access to primary healthcare services for the vulnerable populations. We are ready if you are, Ariel.
Good morning, everyone. Thank you so much for inviting me to speak at the summit today. I'm sorry I couldn't be there in person. I really wanted to be, but I appreciate this opportunity to speak virtually. I am going to bring up my PowerPoint, and please let me know if you have any difficulty. Start the slideshow. Can you guys see that okay? Excellent. All right. Well, my name is Ariel Byam, and I am the Executive Director of the Pacific Islands Primary Care Association. And I am speaking to you today about improving access to primary healthcare services for vulnerable populations. So the objective today is to explore innovative ways to improve access to primary health care for vulnerable populations to achieve health equity. And the first step in doing so is recognizing who our vulnerable populations are. So there are many ways to include vulnerable populations. They can include the economically disadvantaged, the racial and ethnic minorities, uninsured, children, elderly, those with chronic health conditions, including mental illness, people who live in remote or rural areas because they often have barriers to accessing healthcare services, and people who don't have a usual source of healthcare. And we need to keep in mind that health and healthcare problems intersect with social factors, including housing, poverty, and inadequate education. And these are what we call the social determinants or social drivers of health. And it really helps to identify what those social determinants of health are in order to recognize the vulnerable populations that exist in Palau. So looking at social determinants of health, they are broken into 5 areas: education, access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. And these can be defined simply as economic stability includes being able to afford healthy foods, healthcare, and housing. So it's not always directly related to just healthcare, but also all the things that play into a person's health, like the healthy foods and housing. Also, it's known that people with higher level of education are more likely to be healthier and live longer. However, some people don't live in areas with access to education institutions, so that we have to be aware of. Healthcare access and quality refers to timely, high-quality healthcare services, including preventive health, screenings, dental health, and mental health. And then the built environment is healthy and safe places to live, work, learn, and play. And social and community context includes positive relationships, safe neighborhoods, and feeling part of a community. So as we can see, there are many facets that influence a person's health that are beyond just the usual that we think about. And I'd like you to just take a moment. You don't have to share since we're not in person. It's kind of difficult, but think about your community and which of these might affect your patients that you see. So uh, me stop the share and see if that helps. And we'll try again. Can you see the correct view?
Yes, Ariel.
Okay. Um, Interestingly, it's not moving for me now. All right, can you see my slides? Okay. No, I can just, how's that? In the correct mode? Okay. Yeah. Beautiful. No, thank you for letting me know. There's technical difficulties when presenting. So there's not a lot of visuals in the slides, but I just want to make sure that you guys were on the same page as me. So I'll just very quickly run through what we did miss, what the objective was. I let you know, and I described the recognizing vulnerable populations. This is the one that I just wanted you to see, the social determinants of health that I was speaking about. I think it's just important to see how these all interact with the patient and with each other. So just wanted to share this slide with you. And now we should be back to where we stopped. And are we moving along smoothly now? Oh, wonderful. Okay. So I just wanted to get into a little bit about the connection between social determinants of health and primary care. So social determinants such as poverty, lack of health care, and education equals factors for health inequities. So health services that do not address these social determinants of health can increase health equities. So sometimes we can be helping the patient with their diabetes or helping the patient with their oral health, but if we're not also looking at these other issues, we're not fully providing them a full, robust service, which would decrease their health inequities and make them healthier overall. But it's kind of a big ask. So we got to think about what we can do to make that connection between the social determinants of health and the primary clinical care. So our goals are to recognize the social determinants of health that affect our patients and create these vulnerable populations, and then to work as a team to increase access to care. So in order to recognize the issues, you have to have a systematic way to screen patients for health-related needs and discuss the impact these challenges have on their health with them. There are many resources that can be added to your intake form where you can use some of the questions to try to gain some of these issues. But part of it is also changing our mindset of the way we think about our patient care. I know that sometimes in the clinical setting, we have a habit of saying, oh, that patient doesn't come in for appointments regularly. But we really need to change our mindset into recognizing what the issue is and trying to figure out why the patient doesn't come in. Could it be a conflict with their work hours? Or maybe the patient doesn't understand the importance of the follow-up that was prescribed to them. And then instead of saying the patient is non-compliant with medications, again, we ask the patient why he or she does not take medications. Maybe they can't afford the medications. They want to take them, but they don't have the ability to pay for them, so they have to choose. Or maybe they don't understand the instructions fully when we said, to take them twice a day, but not with food, and they're not sure where to, how to take them or what hours of the day. So it's those types of things that really helping them and helping us understand the issues behind the patient's health-related needs. And that next step is to actually increase the access, and that can be done different ways, through navigation and through alignment. So with navigation, we assist the patient in accessing services at times and locations that are convenient. So again, sometimes in our healthcare systems, we have our healthcare systems set up to work in the same business hours that people are also working in the community. So therefore, they don't have the time to come in for their prenatal care or what have you, because every time they would come in for their prenatal care, they would have to ask off for work. And then asking off for work all those days means less time that they can have for time with their baby after they deliver. So it ends up becoming that people maybe don't see the prenatal care as an important issue at that time, because they'd rather spend more time with their time off after they have the baby. So these are the types of things that we have to understand. Are we really offering times and locations that are convenient for the patient, so that they don't have to make these decisions in their life about what is most important? And then alignment, partnering with community stakeholders to more closely align services with the needs of patients. And when we say community stakeholders here, we're not just talking about community groups that offer services, although those are very important stakeholders, but also our policymakers and all kinds of people in the community that can help with this, such as improving built environments or improving housing and those types of things. And it's really necessary for the healthcare system to look just beyond what they do and really look at how these social factors interface with healthcare and how we can support the patient more fully. But the good news is, although it sounds daunting, access to healthcare can change. We can make an impact. And we can do this at the systems level. We can transform the way that health systems and organizations function. And that was some of the things we were just talking about. You can look at internally about how your health system functions and look at ways that we can be more in tune to what the patient needs. And we can support the development of new professional roles and expanded scopes of practice. So possibly looking at if we do need some patient navigators or community health workers, which I know are used a lot in Palau and are an excellent way to look at this new professional role of expanding scope of practice for people to really help patients access the healthcare system. And then we also can make individual or population level change. So we can empower patients to participate in decision-making processes regarding their care. So instead of us just telling them what is necessary, but really helping understand their issues and getting them to get that buy-in and be part of the planning of their care and what would work for them, and maybe that will increase compliance. And then advocating for community-led services is yet another way. So in this presentation, I was asked to speak about some innovative methods to increasing access to care, because it's very easy to just say, well, we'll put up another location, or we'll offer this additional service at our current location, or possibly even we'll change our times of the days or the days that we offer different. There are other things that we can do beyond some of those. Some of the innovative things that are done across the country is looking at clinical community linkages. This can help reduce emergency department visits by promoting preventive care and healthy behaviors, and it connects patients to local organizations to address their specific needs. So an example of this is clinicians can work with local schools to increase access to primary care and dental services for children in underserved neighborhoods. And that's something that we often do with dental care. I know there's a lot of programs that go into the schools, but we can look beyond that and see if there's other things that can be done with immunization or children's health and those types of things. Another innovative method being used is telehealth. Telehealth expands patient access to healthcare service and offers a wide range of benefits. It also provides an opportunity to maintain or supplement access to healthcare services. And it includes multiple modalities, including video conferencing, remote monitoring, electronic consults, and wireless communications. What I mean by this is telehealth isn't just seeing a doctor off island. It could be having a consult. It could be having like a psychological evaluation and then follow-up care with a therapist. It could be two physicians consulting each other. So a physician that's in Palau getting a consult with another physician that's outside of Palau that might have an area of expertise that's not available in Palau. Remote monitoring is something that it decreases the number of times a patient has to come into the clinic. So there's remote monitoring for blood pressure, there's remote monitoring for diabetes, and in this case, patients are given ways of monitoring their blood pressure or their blood sugar from home, and then they either enter that directly into a web portal, or sometimes the best case scenario is that the equipment that they're given has an automatic upload, and the patients are giving that directly to the physicians. And what's great about that is there's interactive ability with that. So physicians in the office, it's not the same as just writing it down and bringing it to the next appointment, because in this case, if there's remote monitoring, providers in the office can actually review those in real time and then send patients back messages that says, you know, I want you to increase your insulin, or I want you to come to the clinic sooner because I'm noticing your blood pressures are starting to go up. So it allows a more close monitoring, and then it also allows for more interaction, but it can decrease the amount of times that the patient has to come to the clinic, which can help with some of those issues of transportation or hours of access. So there's lots of ways to use telehealth, and telehealth is particularly useful for those who have difficulty recruiting or retaining adequate healthcare workforce. And sometimes that can just be the specialists and the difficulty in having people come out to Palau to be able to provide some of those specialty services. Another innovative way to reduce disparities is alternate treatment sites. You can improve access to care by addressing issues with transportation due to geographic or financial barriers. This provides patients access to care at pop-up or mobile clinics closer to where they live and work. And this was often utilized during COVID-19 response, and we saw a lot of great outcomes of that, because clinics were being taken to where people were instead of having everybody come into the clinic. But what was used during COVID-19 response can be adapted for routine care. So now we can look at some of those lessons learned and some of those best practices, and we can say, you know, this really worked to offer these types of services in the community. And this is how we could do it more routinely with a mobile clinic. Another innovative method is to educate the public about multiple healthcare sites. This one's a little bit confusing, but basically it's helping patients understand where they can and should seek care depending on their symptoms. So if they're a diabetic patient who is just noticing that they're having some difficulty with control of their blood sugar in the last 48 hours, they can come to the clinic. They don't necessarily have to go to the emergency room. And it's helping patients understand what needs to be an emergency room visit, what needs to be an urgent care visit, what needs to be a primary care visit, and how they should seek those. And that's a very difficult thing for people outside of healthcare to understand those differences. And sometimes when we give those instructions to patients, we are well-meaning in telling them how to follow up and when to follow up. But it can be quite difficult for them to understand the differences of those types of things. So it's very important to spend a little time on the education of the public about how to use the healthcare sites that are offered and what's available at each healthcare site and what those hours are and what the best use of that is. And this has been shown to reduce costly emergency room visits, and it also increases outpatient services sought. So we actually see that more people use healthcare when they understand it better, because sometimes people are like, oh, I don't want to go to the doctor for that because I don't have an appointment. It's going to be difficult to get, and I'll just wait. If it gets bad, I'll go to the emergency room. But if they had come earlier to the outpatient, they could have had a better outcome or less treatment. So not only does it reduce costs, but it also increases when they come for outpatient services. So this is a very good, innovative way to increase access to healthcare through education. And you might be asking which innovation for improving primary healthcare services for vulnerable populations is best. And unfortunately, there is no one right answer. There's nothing to say that this is absolutely the best way of doing it. So in order to answer this question, what's best for Palau, you have to look at what some of the next steps are. So in order to figure out what you should do, you need to have an understanding of the different determinants, barriers, and needs of your population. And again, you can do that by asking some questions on the intake surveys or by doing needs assessments to fully understand your population. And I know some of these things exist, and it doesn't necessarily mean you have to take on another, year-long project, but look at the data that you do have, see where you're seeing commonalities, and see what you can do in your healthcare system to affect those commonalities. And possibly you have to look at it that each health system or each health program might have to assess their own community, because obviously there might be some things that work for the pediatric population, like catching them within the schools, which you can't do for other populations. Or there might be issues for one program that's different than another healthcare program. So some are health system-wide changes, and some are health program changes that need to be looked at for that special population. And then allow the patient experience to guide the response. I remember one time when I was in Palau, we were doing a quality improvement project, and we decided to take on patient wait time. And someone who was participating in the educational event was actually pregnant at the time. And she used her own experience and mapped out on a large piece of paper the steps that she had to go to get her prenatal care at her first prenatal visit. And it was very interesting to see it from a patient point of view. So here she was, part of the healthcare system, and now as a patient in her prenatal visit. And she said, I never realized the requirements of what we had to do to move around and what the patient experience was really like. So it's very important to get that patient experience and understand from them. And from there, once you understand what some of the issues are in your community, you can really look at some of those innovative methods that have been found to be helpful and decide what would work best in your community or for your program or for your health system. So with that, I'd just like to say thank you and open it up for any questions or discussions in the last 5 minutes that we have. I'm hopeful that we would be able to have some interaction, or if someone there would be able to pass on the information that's being said in the room if I can hear.
Thank you, Ariel, for that presentation. Isn't there questions? Okay, well, it's gone. Anyway, thank you, Ariel, for that presentation. We're moving on to, oh, go ahead.
I was just saying you're welcome. Thank you for the opportunity that I could present.
Thank you again.
Are there any questions in the room?
Are there any pressing questions around? I think we have time for if there's one. Ariel, doesn't look like there's any
Yes.
from the audience. Again, we thank you for your presentation. Thank you, everybody.
Okay, thank you so much. My email is on the slides. If anyone does have any questions or would like to discuss it further, I would love to be able to be available for follow-up. And I wish you an excellent summit. And thank you very much for your time.
You once again. Thank you.
Okay.
Okay, our next talk is going to be on intergenerational trauma, the cycle of abuse and trauma. This is going to be given to us by Father Felix Francis X. Hazel, who is the parish priest of the Santa Barbara Church, along with James Ariola, behavioral health consultant at Bravo Behavioral Health Services. If I can have you gentlemen up the stage, please. Thank you.
Good morning. Ali Tutao. I'm happy to see you all here. Before I begin, I want to give thanks to always to the Lord first, but also I want to thank you all, people of Palau, for welcoming and inviting us and being so hospitable. We're truly grateful to be here with you today and to share a little bit about this important topic. Um, we're gonna, I'm gonna begin first with my portion, and I'll hand it over to Father, and he will end. And hopefully, if there's some time for questions, you can speak on it. But we have more time tomorrow as well, so we can, you can all have some time to meet with him. I'm also grateful to have Father Fran Hazel here with me. For those of you who know him, he doesn't need an introduction. He knows most of us in our communities, and for me, I'm very grateful because my careers has been in mental health and behavioral health, and his works have been one of the few things that we can rely on over the years as we've grown to become young scholars in the field. So I'm honored, and I'm grateful to have him here with us. So this morning, as I begin, we're the topic of intergenerational trauma. It's a very heavy sounding, it's a big word. I don't even know how to translate it in our languages. But I want to take it and look at it from a different perspective and revision it. Before I go in a little bit about who I am, obviously, my name is James Ariola. I am from Saipan, born and raised. I'm a Chamorro from Saipan, but my grandmother's from Kusrai. And you look at me and you say, how is he from, is he Micronesian like us? Yes. But my mom's Irish is also strong in me. But I'm also, as I was sharing yesterday to the group, I've married to a Chamorro Palau. So my daughters are very strong. So just a little bit of a background to share with you. When you hear me talking about indigenous ideas and thoughts, that it's a part of our collective Micronesian history, but also with the uniqueness of my people, and also for the relationships and families that I've built throughout Micronesia as well. So to begin, I want to start as most of us do when we have the chance to meet together, and it's with a story, and it starts off with once upon a time, there was a young lady who happened to be caught in between, a battle between two countries. And they were living in a cave, and they were very hungry and very thirsty. So her and her friend decided that they were gonna go and look for water. And the only place that they could find water was in the banana tree where the rain falls inside. There was a lot of the land was very heavily damaged because of the destruction. And while they were getting water, she got shot in the feet, and her other friend got shot in the feet. And they had to climb all the way back into the cave where when she woke up, she was still alive, but her friend had passed away. And so these are very common stories that maybe you have also in your histories. This is the story of my grandmother. And so I'm sure in Palau, we've grown up with all of these different experiences of the war as an example. And the war is just one of them. But we can look at this story in two perspectives. We can say, aye, this is a story of trauma, or we can say, oi, this is a story of resilience. Because my grandma's story to me was never about what she lost. Even I have to massage her feet every day where the bullet took out the skin. She never complained about how it happened or who did it. It was always a story of the resilience and how they were able to live through it. And so this is an important part of our history, knowing and teaching from within for ourselves. Because growing up, it was hard to find our voices in our history. We had to learn about it from a variety of different sources, which often didn't represent us in the way we understood or the way we knew or the way our culture teaches us. And so when looking at it, as I was mentioning, the way I want to reframe this conversation today is about not a lens of historical trauma, but a lens of resilience. A resilience that we find throughout not just Micronesia, but for our brothers and sisters in Melanesia and Polynesia, despite the many things that we have encountered in our history over the years. Now, if you ask a Micronesian, if you ask us, when we do trainings, I often do my main area of where my heart is in behavioral health. I love health overall, but behavioral health is really where I spend most of my time. And we do a lot of training, throughout the islands. And when we ask each other, how do we define ourselves? We hear that and to use your language first and then to translate into English. No, we often hear that the values that we hold dear to us are our faith, our culture, our tradition, our respect, our ability to navigate adversity, the beauty of our diversity too. Yet, how have we often been represented? Usually when you hear others, what has often been, and hopefully not your experience, but for many of our experiences, when they say, "Oh, how is Micronesia? How are the islands out there? How is it like?" I'll say, "Oh, it's so beautiful. The weather's so nice, but the people are the fattest. The people are the drunkest. The people always chewing. The people always problems." This is how it feels to us, how it's represented. Our health is always told to us from the out how bad we're doing. And many of these statistics and facts, yes, some of them, to some extent, they're true. But what doesn't help in creating this vision of resilience is constantly being put in our face, and not having us at the table being able to describe why these challenges exist and how we're working to move past them and how we're struggling to make our lives better. So, for example, one of the things that we learned is that early on in our discussion about behavioral health, our islands were very innovative. We understood, for example, for many, many years that we couldn't separate the substance misuse work and our mental health work, that it went together very well, and that our capacity required us to have to put them together to solve our people's problems. And many other entities and many other funders or wherever it might be continue to tell us, no, you have to separate, that's not how it works. You have to separate, that's not how it works. And eventually, at some point, they came in and said, you know what, you guys have it right. Actually, we're going to call it behavioral health now, and what you guys have been doing is working out, and we want to try and get towards that model. But if we didn't stay firm together to recognize, if we had did what we have done many times before and say, okay, we'll follow what you say because you know better than us, We wouldn't have been able to create and build the systems that we're currently doing with our cultures and our faiths in the work that we're in our state systems and in our villages. And it's also important to recognize, as we talk about this history of trauma, that we also don't remain, that we don't romanticize this past. That, oh, it was so much better the way it was before. When we talk amongst each other, we know our arguments, we know our struggles, we know our battles, even between families. We also have to recognize our weaknesses, but for them to be acknowledged in our own homes, in other words, at our own dinner table with each other, so that we can grow from these things and not remain a victim of the history of this trauma. And so what do we often, what are some other areas that we hear when we're talking about this history of trauma? You know, what's the dialogue of Micronesia? 1521 Magellan, 1899 the Spanish left, and the German administration came in into 1917, and then the Japanese administration into 1940 something, and then the Trust Territory, and then now the U.S. influence. Where's we want to hear our story, our people. Yes, that's a part of it too, but it's not what defines us. And often in the context of this colonial history, we are constantly fed a perspective that doesn't include our voice. And so what do we do about this now? How can we reframe this traditional system of trauma that we often hear about ourselves and revision it in a way that shows the beauty and resilience of us as a people? Well, throughout the region, when we work and we gather information, we hear that the three things that most islanders want to continue to promote is the things also that we've inherited and that we've shared from these experiences, focusing on the positive, focusing on what we were given and not what we weren't given. There's three things that stand out. The first is we constantly hear the importance of faith in the work that we do and the communities that we do. Our faith communities, our spiritual communities are a very important part. And for many years, oftentimes we've been asked not to include that. But we know that healing cannot occur without this. This is a very important part of our belief, our spirituality. The second thing is culture. Culture. The idea that we constantly want to discuss the beauty and uniqueness of our culture in a safe place where it's us having and learning from each other and not being used for or against us, and as a resource that can better the problems that we see today, even though many of them are new and different than what we've experienced in the past. And we often say, nothing about us without us, and that really means that we're at the table to make these decisions, that our culture is valued sincerely and not as an afterthought, not as, not as the sprinkles at the end. That it's there from the beginning, that it's the core of how we're carrying out the discussion. And I see this too in working with your youth groups, amazing talents that they have, and that the youth of Palau are willing to talk about this, that their faith, their culture, and that it stands as a wonderful example for others in the region to look at too. The youth of my island in Saipan, or in Kushai, or in Marshalls, yeah. And the last thing we often hear about is the importance of land. But when we say land, often in our languages, we don't just mean the land. We mean the air, the sea, the environment, the combination of this, and the importance of it, and how family plays into that. And to be very aware and to be very cautious about who is stewarding our land for us, to be sure that our knowledge and our wisdom and our cultures allows us to be in charge of our lands, and to make sure that, again, we don't get caught in between other people's conflicts. Often when you hear about our islands being described in defense, you don't hear Palauan people, Chamorro people. You hear wall, defense, all of these things. And for many of us, like even the World War II, which is a really long time ago, is still very present in our lives. My sister often writes a lot about the importance of the being very aware of what these relationships mean for us as a people, to make sure that the decisions that we're making for our land, for our seas, also are inclusive of the people who live here and will continue to live here. And so, to end and to move on, because I'd like to have Father to come up and share some of his amazing wisdom with the rest of you all. It's important that we acknowledge these problems that we're facing ourselves and that we talk together about it as a people, starting first from our homes, and then rather than looking out with each other. It surprises me when I share with people sometimes, oh, we have an issue that we're dealing with in Saipan, let's go to Palau and see what they're doing about it. Or let's go to Yap and see what they're doing about it. Why not start first with among ourselves? We know what's best for us, and we have a lot of shared history and region. Why must we always look outside? Now, does it mean there's no value out there? No. There's lots of value in it, but let it be the supplement to what we already know and not the standard for what we always run to. We've seen time and time again, it's not sustainable. And with that in mind, the sustainability is key to help us understand this history that we have. It helps us to acknowledge the past and learn. It helps us to get through these feelings. When you start to learn about it, especially young people, it's learn about our region, about our islands, about our histories. We know more about other countries than we do our neighbors sometimes. It's important that we learn, and when we do and when we hear about these histories, we allow ourselves to feel through it, but to not remain a victim of those traumas. To forgive and to grow in empowerment, as we've learned from the wisdom of our elders, to move forward and take what's good and leave behind what isn't. So that we are navigating this canoe together towards a positive new direction. And instead of hurting each other and harming each other, because when we fight amongst ourselves, brothers and sisters in our islands, it gives power to other places to come pick what belongs to us when we're fighting. So, to have the ability together to work together to fight, we're seeing that. We're seeing wonderful things happening already. In the work that we do in behavioral health, we see in the marshals important work being done for recovery and sobriety around building traditional navigation, canoe, right? In Palau, you have your wonderful youth organizations that are building plans to help the future of their community. In Guam, you see youth training youth about what's important to them in healthy and culturally appropriate ways. In Saipan, you see that the community has been able to reduce the substance use problem by 50% amongst youth by just cooperating together. We have strength in this. There's evidence to show it, but we must now work together to move in that direction so that our story is not one of a history of trauma, but that it's a history of resilience with respect and with hope. So I'd like to call Father to come up and add some ajinomoto to the rest of my, my speech. Thank you so much.
Okay, this is good. Okay, thank you. You're in a house. All of a sudden the house starts shaking. You go over to the sink. You turn on the water tap. There's no water running. And you say to somebody, hey, go fix the water tap. But Mama, the house is shaking. You go over to the other side and there's something wrong. There's a leak in the roof. What do? Fix that after you fix the water tap? Or do you take stock of the situation and say, maybe we have an earthquake here. Maybe there's something big that's going to create other problems. Maybe it's not just going to be the roof and the water tap and a few other things. Maybe it's got that this whole place is going to come tumbling down. Maybe we have to think big. I think that's the situation we're in. Don't think small, think big. Don't think psychological trauma. You know, there's this problem with kids, there's that problem with kids, there's other problems with kids. Let's go to something more fundamental. Let's go to causes. Let's go to something that underlies, some of the changes that have happened. And that is social change. Let me use one example, a physical example. I was flipping through pictures a few months ago. We have a lot of pictures in the old Mike Sem collection. These were pictures of Palau. And I was looking through these pictures. When I say pictures of Palau, I'm talking about pictures in the early 1900s when the Germans were out here. And when they had, shortly after they invented cameras, when guys were going click, click, click every time they'd see a group of people, including the Kaiser's birthday, which was a big celebration. I was looking through these pictures and I kept thinking, I said, everybody looks so thin, slender. Isn't anybody overweight? And then I found a picture of Ibadul in the 1880s or 1890s. And honestly, that was the one individual that you could call overweight at that time. And I'm not exaggerating. So, what happens? What happens is physical change, lifestyle change, social change. What happens is the taro patch work isn't done as much, maybe not done at all. The fishing offshore isn't done the same way. People don't walk as much, and they don't walk as much, barefoot. The fishing is done with 200 HP motors on the back of the boat rather than, paddling canoes. A lot of things have changed. And this has created a situation in which we're dealing with NCDs, non-communicable diseases. These are the social changes that shake the house. These physical house, and create a situation in which we have to deal with a host of new problems now, physical problems. But I'll go on using that as an example to say there's not just physical problems, but there are behavioral problems also. And these things, it might be good to ask ourselves, if the house is shaking, what's going on? Let me try to address that briefly here. In Chuk, where I lived for 25 years, I heard a story from somebody. I was going around asking people about the memories of the old days. And this woman was laughing when she was telling me the story of her husband and her husband's first job. The first job was working for the Chuk government, the Trust Territory government. And he brought home his paycheck every other Friday. He brought home the paycheck and he gave it to his wife's uncle, who was the head of this group, this little sub-village, this Aterias, as they call it in Chuk. And for the first 2 weeks, the wife's relative took it. And then finally, he said, no, you keep this. This is yours. You earned it. It's your salary. It's no longer something that's brought in, like breadfruit, to be pounded. It's no longer something that's to be contributed to the whole group that's supposed to be the basic family or extended family group in Chuk, but it goes into the pocket of this the father who earned it. That means that he takes care of the money. He takes care of the 4 kids and his wife. And so, a couple weeks later, he comes back, Friday, payday. He comes back with a bag of groceries. He's spent this money. He comes back and he sees 2 little eyes peering over the windsill in the window. As he's taking the stuff out of the bag, he gives a package to this little kid and some ramen or some soup or something like this. And the kid smiles and he runs back and takes it to his own nuclear family living in a different house on the same parcel of land. He's acting generously, but it's his decision where the food goes. He is the one in charge of his nuclear family now. He's feeding them, he exercises authority over them. Sorry, but that's a rule of life. At least it's a rule of island life in Chuuk. So, what this means is that he takes care of the people, they get the jobs, they take care of the food, feeding their family, and the kid depends more and more on father and mother. But what about the old days when he used to go to the uncle? Because uncle was a big thing, maternal uncle. It must be here. I'm sure it is here too. No, not quite as much. Of course, it still means something. Of course, there's still rituals connected with it. And of course, parents always say, you have to respect these people, you know, particularly the people on the mother's side, because that's our culture. But when push comes to shove and when decisions are made, those decisions are made by mama and papa, not by the maternal uncle. And what that means is if a 14-year-old kid complains to his father that he's being treated differently from his older brother, the older brother can go to the father and ask for things and get these things, and this kid can't. He can't go in the same way to his other relatives, his maternal relatives, is sort of a balance. That's why they used to tell me that, oh, don't you understand that the maternal family, the lineage, is the hull of the canoe, and the father's family, the individual family, the father's especially, is the outrigger, the tam, as they call it in Chuuk. You need this whole thing to sail. Well, I guess it got broken. I guess it got broken because a lot of things happened in the 1960s. I'm not going to talk all day, but I'm going to, I want to give you a little historical example of what I mean. In 1991, there was a visiting commission of the UN visiting mission, came to Micronesia. And they were not impressed at what they saw. They wrote up a report. The report went to Washington. President Kennedy was the president at that time. He read the report, and he said the report was, you are neglecting the people of Micronesia. The U.S. policy at that time, after the war, was let them alone. Let them do their own thing. We will not exercise the same control over them that Japan did. We don't want to be Japan. Fine, but in 1961, Vietnam was just starting to heat up. In 1961, America was beginning to fight against communism, the battle for the hearts and minds of the third world, as they called it at that time. And now the UN visiting mission is saying you can't even take care of your own trust territory, never mind Southeast Asia. Kennedy was shocked at this thing, and the government changed its policy overnight. 1962, 1963, the budget is doubled. The budget increases 10 times by the end of the next 12-year period of time. That's by 1974. Jobs, new jobs created. These jobs become offered to Micronesians. There's no single pay scale, but the scale goes up. The pay goes up enormously. Instead of getting 25 cents an hour as the minimum wage is increased significantly. Many more people have jobs, and so there are many more people like this father in the family coming back with their paychecks, you see, buying their own groceries, taking care of their own families. This is going on from the early 60s, on through the 70s. There's more money around, and there's more work. And there is a fragmentation of the family that occurs. And the fragmentation of the family coincides with the increase in suicide. The increase from just, well, let me put this in terms of the suicide rate. A rate of about 3 or 4 per 100,000 a year to a rate of about 30. In other words, the rate increases 10 times, even as the population is increasing. Tomorrow I'll show you the numbers for that thing. But is this an accident that these things happen at the same time? The increase in money and the fragmentation of the family and the huge increase in suicide also? What about delinquency? Were we experiencing the same thing there? Remember, it takes a whole village to raise a kid. And maybe it takes an extended family to raise a kid. But the extended families aren't as easy to find, or at least it's sort of hands off, much more now than it was before. Adoption. When I got to Xavier High School, I asked somebody once, a class, I said, how many of you were adopted? And about in a class of 30, about 18 or 19 raised their hands. Would you get that now? A lot of things have changed, folks. And what I'm suggesting that we do is look not just at the cracks in the ceiling and not at the water, whether the water is flowing, but what's going on, what's shaking the foundations. And I'm suggesting that not that we throw up our hands in despair, but that we settle down to the real task of how do we deal with these changes, because they can be dealt with, but we have to understand what's happening. I'll leave it there. Thank you.
Thank you again, Father Hazel and James, for your presentations. Folks, just a quick reminder, please have your cell phones on either silent or turned off or muted. Thank you. Our next speaker is Emi Chutaro. She is the Executive Director for PIHOA, Pacific Island Health Officers Association. Okay, Amy, whenever you're ready.
Testing. Thank you so much. Ali ungil tutao. In my language, Yahweh inchupungan kumolib. First of all, I just wanted to say thank you so much for this kind invitation from the Palau Ministry of Health and Human Services to speak in front of you today. But most importantly, the opportunity to learn, to listen, to hear all the wonderful things that are happening here in Palau. I have to say, I have been so incredibly blessed to hear all the wonderful work, the dedication, the passion, the resilience, the hard work, despite COVID. So I just wanted to maybe just start and say, folks, Ministry of Health and Human Services staff, all the people that have been organizing the summit, please stand up. I just wanted to say thank you so much for a wonderful job. Well done. So as Gustav mentioned, my name is Amy Chitaro. I'm the Executive Director for PIHOA. I have been in this position since October of 2013. It's been an interesting journey. Almost 10 years. I didn't think that I could survive 10 years in this job, but I have. But mostly because seeing and working across all of our island nations, seeing the challenges that everybody has so bravely addressed continue to work in the health systems despite all these challenges. And equally, the dedication to help just keep our families and our communities safe and protected has been what has been my heart, my true north to continue in this work. So there has been a lot that has happened with respect to the work in the regional level to support each and every one of you here in this room, but also our brothers and sisters and cousins in the other islands, to see where we can continue to improve, to continue to expand, enhance our health services for our island people. So today, I was asked to speak about one component of the work that we do at the regional level, which is around workforce development, and how we then look at health equity to continue to enhance, improve the health workforce development work that we've been doing across all the islands, and also here in Palau. So next slide, please. So just a quick summary of PIHOA. We were established in 1986 by the health officials of the U.S. Pacific Islands, so that includes American Samoa, Guam, Commonwealth of the Northern Mariana Islands, Federated States of Micronesia, Palau, and the Marshall Islands, where I'm from. We were initially established really to address this issue of identity and of advocacy particularly with the United States government. As mentioned by Father Hazel, there was a lot of history in the background to ensure that the island vision and the island voice was not left behind or consumed by other national priorities, particularly with respect to the United States government. So a lot of our initial work was really around advocacy, bringing together that collective voice and that collective power of our health officials, and use that then to work with the United States government and now with our international partners and other funders to say, hey, these are the priorities of our islands. Please work with us. Please consult with us to make sure that whatever opportunities there are to enhance and support our health services is aligning with our needs. It's supporting what our priorities are on the ground. So we continue in that work, but as time moves on, we've also then started delving more into what we call regional policy and decision making, working with our regional international partners like the World Health Organization, like Congress, like the White House, to make sure at the high level policy discussions, again, the Pacific voice is there. And more recently then being able to provide actual technical assistance in certain areas. So now I wanted to just acknowledge that we have a new governing board president. Your minister, Gafar or Palau, I'm not sure, I don't see him where he's, there you are, right in front, sorry. Who is now our PIHOA board president. And I have to say that when he was elected in October of last year, he has already had all these conversations with me about, Amy, let's focus on this. Let's tweak and change this. Let's really make sure that the island voice is well heard and articulated in all of our engagements with our partners, with our even our health leadership at the executive and legislative levels in the island. So I just wanted to acknowledge that already, just only a few months into his presidency of the governing board, he has already expressed a very strong vision to see where we at the regional level can be better support for all of you to protect our communities. Next slide, please. Oh, next slide, please. So I'm not going to talk about health equity. I think yesterday we heard a lot of different perspectives and different definitions and sort of different iterations of what health equity means. How it then aligns with sort of all the different activities and areas of work across the health sector. Specifically for this presentation, though, I'm going to kind of highlight a couple of things in terms of the lens that I'll be speaking about with respect to health equity, how that supports a diversity in the workforce and inclusion in the workforce. So we at PIHOA, our core principle of operation, for lack of a better way of describing it, is island-driven health system strengthening. Workforce is one very critical component of that, but it's not the only component. There's health information systems. There is ancillary services, enhancement and support. There's leadership, there's policy. There's just so many different aspects of it. But specifically for health workforce development, I'm going to talk a little bit about what are some of the things that are happening at the regional level to gather data, to support workforce development initiatives at the regional level, not in competition with what you're doing at the national, state, and island level for workforce development, but to enhance that, to support that, to scale it up. The other lens that I also wanted to note is island focus, leadership enhancement, and networking. That is such a critical aspect of health equity. It's about our communities, it's about the individuals, it's about the staff who are in the health departments, but our leadership too also need to be part of the health equity conversation. So we have looked at some activities and some engagements at the regional level to support our leadership, not just the leadership at the level of the ministries and ministers and secretaries of health, but also leadership across all of you and how you all can work together as health leaders with our brothers and sisters across the other islands as well. So I'll touch on that a little bit. But lastly, I wanted to acknowledge Senator Corte, who was also a previous PIHOA board president, when he had talked about wellness as an asset and as a public good. I added this slide here. Sorry, next slide. Oops. I added this slide here to talk about maybe one more aspect of health equity, and that is that our Pacific Islander health workforce is an asset, and they should be seen as a regional public good, not just at the national state level, but regionally as well. So there is an asset here amongst all of you and amongst all of our health workforce across the islands that we need to acknowledge and we need to value, because they're the frontliners. They're the ones who are out in the trenches. And when we're talking about health equity, our workforce must be valued and must be supported. So there's going to be some aspects of health equity that I'm going to talk about in terms of empowerment, in terms of how we can capacity build and build up the skill sets of our health workforce so that they themselves feel empowered. The community sees that they have valuable skills. They value those skill sets, and they acknowledge and they express support and gratitude to our health workers for the good work that they do. COVID has clearly shown that we've seen both sides of the divide. We've seen communities and leadership who've been very supportive of our COVID responses, but we've also seen communities and our leadership very critical of our COVID responses. How do we bring that together and look positively forward, and really acknowledging the resilience, the skill sets that have been clearly demonstrated and highlighted throughout COVID. So I just wanted to acknowledge James's point about resilience and the positive thinking moving forward, and I think we need to have that as well within our healthcare system. A lot of us are traumatized. A lot of us have hit many walls. We've seen a lot of our health workers in the corridors crying, bruises around their eyes and noses and mouths because they've been wearing masks and goggles for hours and hours on end. So just wanted to note that we really need to reshift. If we're talking about health equity from a workforce lens, it also needs to include valuing a workforce as a critical asset in the health equity conversation and as a regional public good. Next slide, please. So I'm going to speak a little bit. And again, I just wanted to note, it's a little bit, for me, I'm sort of standard presentation, PowerPoint. Following Father Hazel and James, I'm sorry, it's not as interesting, my presentation, but I'll try my best. So workforce, again, at the regional level, there has been a lot of conversations. Priorities around workforce development have been number one since day one, since PIHO was established in 1986. But I'm not going to go over all of that. Fast forward to 2006, our island leaders got together. They declared a declaration, what they call the Nalap Declaration. There's a Nalap Island in Pohnpei state in FSM, where they set the stage for ensuring that there was a priority statement, a strategy put forward for workforce development and priorities across the Pacific region. This was a several-day meeting, a lot of contentious discussions, a lot of consensus built, but in the end there was agreement that this could not be left alone, this had to be addressed, and no individual island jurisdiction could do it alone. We had to do it collectively. We had to find resources that is available at the regional level that could better support each and every one of you at the island settings. So even though it was developed in 2006, in reviewing that Talungab Declaration today, the core principles are still as cogent today as they were back then. So there hasn't been really significant changes in that strategy since. And there have been some reviews done since then in terms of how that has been implemented. So back in 2010 into 2011, there was a very comprehensive review. There was massive consultations had with each and every one of your health departments in the islands to say whether we have progressed or whether we have not, or are there still gaps? Are there some innovations and new things that we can consider in terms of workforce development? Fast forward 10, 13 years on, and I think with COVID hitting us pretty hard, it was very, very clear that we weren't there yet, right? COVID really showed a lot of gaps still in our workforce skill sets, how we recruit, how we retain, how we enhance and empower our health workforce, the policy environments in which we operate. There were still very, very significant gaps, a lot of improvements, but very still significant gaps that require us to reflect, rethink, refocus, and say, where have we gone wrong? What can we do better? And how do we go about doing it better? So priorities for workforce continue. And to take the next step then, there was agreement by the health leadership in 2021, so 2 years ago, to progress towards then doing a very comprehensive assessment of our health workforce across all the islands, across all health sector, both public and private. So next slide, please. So this is where we're at today. We have a survey tool that has already been developed. This was reviewed on multiple occasions by our health leadership, including Minister Kafar here. There was another consults with our HR focal points across the islands if they had one. And this data collection tool aims to collect a very wide range of information in terms of who is in the workforce, what are their skill sets, how old are they, where are their positions relative to the organization, how are those positions meeting the overall strategic needs of each of the island health departments. And it's not just looking at hospital, it's not just looking at public health, right? It's also looking at community-based services and care. It's looking at not just your nurses and doctors and your laboratorians, but also your health administrators, your managers, your finance people, your people who are in the background making sure that the wheels and the oil are well honed so that the wheels can move and you can do your work. We also are looking at the pipeline for workforce development. So looking to having consultations with your local community colleges who have nursing schools or associate degree in health sciences. Those consults are also happening to kind of identify not only what the current health workforce looks like, but what is then the potential for pipelines into the health workforce. Is that adequate? Is that sufficient? Is that meeting the needs in terms of competencies and skill sets needed? So thus far, we've completed American Samoa, Sinai, Palau, and RMI, and hope that FSM and Guam can be completed by the end of March. We'll see. FSM is a little hard because it's 4 states, so we'll try and make sure that we can get that done as soon as possible. But in parallel to this, we're also developing a database. So it's important that that data is not only collected, but that data is analyzed it is revisualized and shared with each and every one of you, and shared with each and every one of our health leadership. So we have a contract in place with Data House based out of Hawaii. They've been doing a lot with COVID. They did the Talungab Pass, in American Samoa, some of the work with Hawaii Department of Education and Health. So they come with a very, very, very good background and skill sets, and already have work projects already occurring in the islands aside from our contract. So we're hoping that this database will be accessible in public domain. But we are first needing to have conversations with the health leadership about how much of that information is public domain, and whether there are some sensitivities as to the types of information to be shared. So that's still a work in progress as we speak. And the funding for that is sourced from both CDC and HRSA. Next slide, please. So some of the early findings of that assessment have been quite interesting. First and foremost, when the assessment was done back in 2010, 2011, almost no island jurisdiction had an electronic database in place to capture all the information around their HR. A lot of it was still very paper-based. Sometimes they had a little spreadsheet, Excel spreadsheet here and there, but there was really no formal systems in place. Fast forward, at least for the islands that have been reached, pretty much all of them already had an existing database of some sort in place. So that's a huge progress, wonderful. And that has made the data collection a little bit easier because everything is pretty much already captured in those systems. Still, the challenge has been on the private sector side. So on the public sector side, a lot of those systems are in place. But when we talk about our private providers and we talk about some of our other community-based organizations, they often don't have those systems in place. So it's a little bit of sort of playing a bit of catch-up across all the different service levels to make sure that all the collected information is accurate. The other thing that we've seen is that there's a lot of differences, a lot of different ways of describing roles and responsibilities. So somebody that is a practical nurse in American Samoa, sometimes his or her job duties are different to, let's say, a practical nurse that is in Guam or the CNMI. So there's some classifications and sort of realignment that need to be had so that the data is comparable across the region. And that's going to be a lot of work. In fact, that's probably going to be 60% of the work right now with the data cleanup to kind of do that sort of realignment and just making sure that things are cross-tabulating correctly. What has also been very clear in this initial assessment is the pipeline for nursing and allied health. There is a severe, severe lack of both capacity and faculty to support, particularly the pipeline training into the health workforce. We've been hearing from all the community colleges that have a nursing school, all the community colleges that have some kind of health sciences program. Every single one have indicated that they are struggling to find faculty. And that is going to cause a backup in years to come in terms of who are going to be participating in these opportunities if there's not enough faculty to teach them in the first place. So this is a crisis, I think, that we really need to highlight as part of the findings of this report. COVID, a lot of us got a lot of funding through COVID. A lot of new positions were stood up. A lot of people were hired. But then there's now a question as to whether we can sustain those positions. Is there enough funding to make sure that these positions continue? Big question mark right now across pretty much everybody. And as you all know, and every single one of you here can be like, yep, is a lot of us wear multiple hats. Yes, we're a clinician, at the hospital, but we also moonlight over at public health, and sometimes we go over to the community health center and help out as well, right? So when we're doing this enumeration, it's very important that we don't duplicate, that we deduplicate. We make sure that instead of just purely counting heads, you want to make sure that that same head is the same person that you've counted who was at the community health center, is the same person that you counted who was then also working at the hospital. So we want to make sure that that is correct and accurate. What I don't have here, though, is I wanted to mention when we were already looking at some of the data around age of the workforce. Sorry, I didn't have this in here, but For some of our islands, as high as 40% of our health workforce will be retiring within the next 5 years. For some of our jurisdictions, that is a critical, critical, critical issue. So when we're looking at sort of the compounding factors of the pipeline, lack of faculty, of course the resources to continue to sustain and support our current workforce, but then moving forward, we then have, anywhere between a quarter to a third, sometimes 40% of our workforce now retiring in the next 5 years. Is there enough coming into the healthcare sector? We don't know. And so I think this is something that is going to be a long conversation with our health leadership through the guidance of Minister Kafar to see how we can really address some of these critical, chronic, acute issues within the next 5 to 10 years as a matter of urgency for the region. Next slide, please. So next steps, we will be having an executive board meeting coming up in April in Honolulu. There is funding to convene all of our HR, workforce development contacts, focal points in the islands to come together at a regional meeting to review this data, to have some critical discussions about strategic directions moving forward and how that can then be proposed to our health leadership in terms of opportunities for strategic planning, resource mobilization, technical support moving forward. Next slide, please. So just as an example, here in Palau, Dr. Christine Qureshi, our workforce development coordinator, had been working with Darnell and team to start looking at your job descriptions, for example, some of the classifications. I know Palau is going through a pretty rigorous, extensive reform process with the hospital and public health, so obviously a lot of job description classifications have to be pretty much redone and realigned across that new organizational chart. Next slide, please. So I'm going to shift gears, and I'm going to talk about 3 specific programs that we have at PIHOA at the regional level that we very conscientiously have worked many years to design, to resource, to make sure that we have the right capacity and capability to sustain it, but really trying to answer very deeply those critical questions about the pipeline, upskilling, empowering our health workforce. So one program is the Pacific Public Health Fellowship Program. This is a very new program that has been in existence for the last couple of years. It's still norming and storming. There's some ups and downs. There's a few more tweaks that still have to be made. But the intent here is recognizing that we don't actually have formal public health training programs in most of our islands. It might be a certificate here or a course there that is integrated into the nursing school, but there's actually not a dedicated public health track in a lot of our schools. So with funding from CDC to kind of start this process up, we have this program up and running today. It's a 2-year intense competency-based public health training program. And it's targeting our young people who are either already sort of on track to the health careers or who may be interested in going into health careers. And we're hoping that these will be our future public health practitioners and our future public health leaders. So it's targeting the associates and bachelor's level Pacific Islanders from our islands. Most of them are coming with very limited public health or other health experience, but they have a keen interest in public health. Again, it's a 2-year assignment, so this is a commitment that they have to make to the program, and that they already need to start thinking about what are some of the key focus areas that they might be interested in. So some are placed, for example, in the laboratory, some are placed in the HIV/STI programs, some are actually placed at the community health center, so it's quite wide-ranging in terms of where they're actually placed. Host sites, as I mentioned, ministries, departments of health. We've also have folks in the community health centers. There's been discussions as well to expand that out to health dispensaries, potentially to other providers, like for example the Red Cross has potential opportunities there for public health fellowship placements. An allowance is provided. We recognize that this is a financial hardship for many of our island folks. So we've worked really hard with CDC to make sure that there's some allowance set aside to enable our Pacific Island folks to be able to sustain their participation in the program. And there is an annual application process. So even though it's a 2-year program, it's a rolling annual application. So as folks cycle in, we have folks cycling out, we have folks cycling in. Next slide, please. So how this works is a health department indicates that, hey, we would love to have a fellow. We have some programs here that are needing extra help. So CNMI stood up and said, you know, we really need some support in our NCD program, particularly with our community-based outreach work, and we would love to have a fellow. Tinian Community Health Center in CNMI also said, hey, you know, we're in the middle of COVID. We have to do these massive immunization runs. We just need, you know, a fellow to come in and help us to get that going in terms of immunization record keeping, you know, all that. So there's a lot of conversation that is had with the health departments, with the host sites to say, you know, do you have a host site supervisor that is willing to mentor and support that fellow? And when we're able to work that through, then a work plan is developed collaboratively with the host site supervisor, with the fellow, as well as with the health leadership to say, is this fellow well placed? Is this fellow's activities focused on the priority needs for that program and for the island? So it's really critical that those work plans are adhering to and aligning to each and every one of your priorities at the program and department level. Fellows do have a program, though, that they have to follow. There are some requirements that they have to complete and pass in good standing. So it's not just participate, but they actually have to show that they're gaining competencies, that they're able to apply those competencies that they've gained in the field. So there are mechanisms to make sure that we can test for that, we can evaluate that, and we can say with confidence that they're actually learning and can apply those skills moving forward. And as the opportunity arises, you know, depending on what other projects are in play at the region and with our partners, sometimes we can pull our fellows into, for example, we have a mosquito vector surveillance project happening in the RMI. We're trying to see if we can pull some of our fellows to participate in that so they can see what it is like to set up a surveillance system for mosquitoes out in the community. You know, NCD hybrid surveys. So Palau is getting ready to ramp up for your second round of NCD hybrid surveys, which I'll talk tomorrow about. But hey, you know, why not have your fellow be part of that process to go out and enumerate households in terms of NCDs, maybe collects, you know, maybe help collect, you know, blood pressure, weight measures. So it's very important that we can give our young island people not only the didactic knowledge, but also the experiential knowledge so that they actually know how to apply these skills in the field. And if we can, and if funding is available, we also bring them along to a lot of our bigger regional forums. So when we have the PIHOA board meetings, we bring the fellows in so that they can listen to our leadership. How are our leadership thinking? What are some of the struggles that they have when they're making a decision? You know, are they always in agreement? No. But it's good for them to see that, you know, policy making at the regional level. And participating in regional conferences, particularly the Association of Public Health, American Public Health Association meetings, etc. So right now we have 15 fellows, CNMI, FSM, Guam, Palau, and the RMI. Here in Palau we have one. And I want to see if please stand up, Hope, yay! Thank you so much. So Palau has one fellow, and we really hope that Hope won't be alone. Oh, 2 now. Oh, at the lab and Dilsey. Oh, okay, 2. My apologies. We have 2 fellows now in Palau. And let me just take a bit of a quick break here to introduce Dr. Yvette Paulino. Please stand. She is the Pacific Fellowship Program Coordinator from PIHOA. Thank you. So if you guys have any questions, please do ask her. Clearly, I'm a little bit behind in my knowledge. Next slide, please. So the next big program at the regional level that I wanted to share with you, and this has actually been going on for quite some time, since 2014, and this is the SHIP. It's the Strengthening Health Interventions in the Pacific. This is very much focused on building our data capacity, our data and surveillance capacity within our health workforce. It is an accredited program with the Fiji National University, and it is a program that is in partnership with the Pacific community, with the World Health Organization, with CDC, and some other partners in the Southern Pacific, particularly National University out of Australia. This program, again, is not meant to be something that happens out there. It's a program that is implemented on site. It's implemented in your health departments, and it is drawing from your staff that are working in any touch point for data, either as data collectors, either as data managers, either as people that need to use data to inform policy, to drive decision-making, to advise on program improvement, et cetera. There are 3 tiers of this program. The first tier is a postgraduate certificate in field epidemiology, or as many of you probably know, the acronym DDM. So DDM is tier 1, it's a postgraduate certificate. Tier 2 is the postgraduate diploma in applied epidemiology, and tier 3 is the master's in applied epidemiology. Again, all 3 levels are accredited by Fiji National University, and is currently implemented now across all 6 Pacific Island jurisdictions. Next slide, please. So just to kind of give you a quick summary of where we're at since 2014, we've had 282 participants that have gone through the program. This equates to 53 courses that have been conducted both at Tier 1 postgraduate certificate and at Tier 2 postgraduate diploma level. We have ongoing cohorts that are happening in the CNMI, Guam, RMI, hoping that within the next few months, American Samoa and Palau can continue additional cohorts. And I just wanted to recognize Palau is the first jurisdiction that actually now has candidates who are eligible, who have completed Tier 1, Tier 2, and who are not eligible for the master's courses. So I think there's a couple of you who are here who are, please stand up if you're graduates of the, oh, don't be shy, stand up. I know there's a few of you out there, don't be shy, please stand up. This is not an easy program. It's very intensive. It is epidemiology. Even some of the things that are covered, I'm like, oh my God, I'm glad you're doing it, not me. So it is very intense. So the fact that they actually are able to get to the master's level, I just want to say congrats, good job, awesome. As I mentioned earlier, there's an opportunity here with SHIP. Because it is talking about data, it is about data capacity, it's talking about improving health systems. I want to take this opportunity to say, moving forward, as we're in this forum today talking about health equity, let's use this opportunity to incorporate the health equity lens into some of the projects and some of the work that is ongoing in the program. So as part of the field epidemiology training program, each student is required to do a research project. So both at the Tier 1 all the way to the master's level, they are required to do a very rigorous data collection, data analysis, and data review project. Here are some examples of projects that have been completed in the last few years. So, not only just your standard communicable disease reports, but also the SOPs. A lot of our islands are churning out a lot of data, but they don't necessarily have the backup of the framework of the policies and procedures and protocols to ensure consistency and quality of those over time. So some of our students actually said, well, maybe I'm not so much going to be focused on the data itself, I'm actually going to focus on the SOPs. I'm going to look at the structure of how we gather data, who manages that data, and how do we ensure that there's consistency in how that is reported out. So that's highly acceptable. NCD monitoring and surveillance plans and strategies, NCD profiles. More recently, we've had more and more students interested in looking at quality improvement. So looking at key performance indicators and understanding how to collect those and how then that informs decision-making for program improvement. They also are looking at health information systems. So what are the types of systems that we need to put in place that are appropriate and user-friendly and manageable and sustainable within our healthcare systems? Patient registries, are also another one. The other one that I've sort of in my lane a little bit is looking at procurement and recruitment. So looking at administrative processes within our healthcare system. How cumbersome are they? I think most of us will say it's pretty cumbersome, right? It takes months, sometimes years to recruit positions. Sometimes procurement takes months and months and months. So we need to understand that from a data perspective. What are those data points? What are those bottlenecks along the line? And then how can we use that data to say, hey, that's specifically where we need to target, and this is how we can look at improving that. But again, using this program to be sort of that conduit to do that type of research is going to be really, is an opportunity. And last but not least, data-driven policy briefs. Some of our students have taken some of that data that they analyzed, and they've then developed policy briefs that they can then submit to their health department leadership. So there's a lot of opportunities here, again, to look at the health equity lens, to look at how your health equity data and your health equity indicators that you're norming and storming here today and with the health department, how can some of those be integrated with some of the projects that are ongoing for the new cohorts coming up here in Palau? Maybe the master's level folks, this could be a brilliant project for someone. Next slide, please. So just to recognize, not only are we talking about training and providing opportunities for research, but then taking that research and publishing it, right? Making sure that it's in public domain. So part of the process is to help our students learn how to submit to a peer-reviewed journal. There's been a lot of folks that come back and they get redlined. It's like red, and they work really hard to just try and make sure that they can do that. So that's part of the training and mentoring process that we do in the program. And these are just some examples of some successful stories of folks that have published their work as part of the SHIP program. And I just wanted to acknowledge Mindy and Irish as some of the two that have been very prolific in publishing their data. So congratulations. And we also had the opportunity to be able to send some of our island folks to present their projects and their findings at the Council for State and Territorial Epidemiologists annual meeting. So really ensuring that our island voice is heard in these big national forums is really something that is so beautiful to see when we have confident, skilled leaders talking about our data from our islands and what does that mean moving forward, and sharing that with not only our colleagues in the United States but with the world. That is tremendous. So just shifting gears now to the last program that I wanted to talk about, and that is leadership enhancement and networking. And when we talk about leadership, at the regional level, we're not just talking about our ministers, directors, and secretaries of health. We're also talking about servant leadership, leadership amongst all of us. And so, even though our touch point right now is still with a lot of our health officials, we are very cognizant that when we're talking about leadership, how do we ensure active participation of everybody in the health workforce in leadership enhancement opportunities and discussions? So we're still working through that. We're not there yet. And there's been some good examples expressed in the last couple of days on what some potential ideas could be supported at the regional level. So thank you all for your inputs on that. But where I think we stand here at PIHOA is really to be the staffers and the support for your health leaders. They do a lot. They're here on the ground working with each and every one of you, but they're also leaders at the national, regional, international level. And so where we come in at PIHOA is to be that support network for them so that they're effective in their leadership and advocacy work abroad. So we do a lot of work in the background to support the logistics, drafting resolutions, identifying data and research that can support some of their advocacy work at the international level. This is where we come in to support them. However, we also have at PIHOA what we call regional professional associations. So these are the American Pacific Nursing Leaders Council, the Northern Pacific Environmental Health Association, the Pacific Basin Dental Association, the Pacific Basin Medical Association. There's about 13 of them across the region in different areas. And so part of PIHOA is to support them as well. I know some of you are. I see a number of familiar faces who are part of these associations. And we've tried very hard to identify funding to convene these professional associations together. We've tried very hard to consult. It's been a little difficult these last 5 years because of lack of funding. But the intent is still there, the need is still there. And the leadership component of that is, for example, with NPEHA, the Northern Pacific Environmental Health Association. Several meetings were had over the last few years, pre-COVID, during COVID, and there was a lot that came out of that. And where we come in at the Secretariat is to feed that information and that advocacy into the PIHOA board meeting process. There have been resolutions that were submitted, for example, by the Pacific Basin Dental Association to look at oral health and oral cancers as a critical priority at the last Palau meeting back in 2019. And as well as looking at, for example, the Association of USAPI Laboratorians, so Manasa and others here can also attest to that there had been resolutions submitted by AUL to the PIHOA leadership about prioritizing laboratory and ancillary services as part of the workforce development strategies. So leadership at that level is also highly critical because the professional associations are each and every one of you, people who are in the field, people who are out doing the really hard graft work. So I have two last slides here, and I'm just kind of finishing off here. Leadership development, as part of the framework for achieving health equity is critical across the healthcare system, irrespective of roles and responsibilities. We all, every single one of us in this room has a duty of care to be a health leader, a champion, an educator, a promoter, a role model, and an advocate. Each and every one of us here. It's not just Minister Kofar's responsibility or Cher or Dr. McCall's. It's each and every one of us. And it should be in part of everything that we do every day. It's a challenge to us all to be servant leaders. If you have heard of that term, we're all servant leaders. How can we all do that together, collectively, every day? So, my last slide. Thank you so much. Kemasulang, kumotada. I really appreciate the opportunity and time to be with you all today. Great work.
Thank you again, Amy, for your presentation. Folks, our next topic will be on accelerating social protection programs to improve health equity for vulnerable populations. And folks, this is a group panel, so please bear with us as we organize ourselves up on stage. Kumam Sulang, thank you. Wala tigel kulita tigel panelist malor ertir sel dil as soon as ready state se kom pabe Sulang. While we're doing that, folks, I'd just like to remind everybody again to please put your cell phones on mute or either turn them off. Please. Thank you. Ndira kang ngaring yamla plate rail 6111. Please sa mo bramli mangara no parking zone. Ako bang klilaad nding jakal sokal duli. Please sa mo bringi. Kaya kuli titigil mera next panel luktakang merbab mera stage.
Mr. Mario Retama.
Mr. Mario Ratamal, are you here in the room? If you are, please make your way to the stage. Also, Ms. Lourdes.
Good morning, everybody. My name is Alila Nyermang, and I'll be facilitating the next panel on accelerating social protection programs to improve health equity for vulnerable populations. Universal social protection is critical to effectively protect people against poverty, prevent risks to their livelihoods and well-being, and help them access economic opportunities. Social protection aims to protect investments in people and access to productive work, resilience to shocks, and equality of opportunity. To reach universal protection, the government needs to integrate services such as social insurance, social assistance, and economic inclusion programs, ensuring all people are effectively protected throughout their life cycle and across income levels. This is especially a challenge when serving vulnerable groups who are already unseen and underserved much of the time. Concerns of groups such as persons with disabilities, the LGBTQ+ community, the very young and the very old are many times go unacknowledged, which is why I'm honored to facilitate this discussion on accelerating social programs to improve health equity for vulnerable populations, to have an earnest and open dialogue in order to identify the gaps in our current systems. Without further ado, I would like to introduce our panelists. We have Ms. Cassandra Singeru, member of Omagasang, Palau's premier organization by and for persons with disabilities. You may be familiar with their work. Every year, they hold an annual parade sometime in the beginning of December to commemorate the International Day of Persons with Disabilities. We have Ms. Eunice Aguiwo, the Director of the Bureau of Domestic Affairs at the Ministry of State, which also houses the Gender Office. We have Mr. Clarence Masayos, the President of the Council of Aging. We have Mr. Mario Retamal, the President of the Filipino community in Palau. They host that amazing fashion and beauty contest every year. We have Hana Nguru Ulbav. She is here to represent women's interests on our panel. We have Mr. Dwight Alexander, the President of Palau Parents Empowered, an organization which offers support, education, and resources to parents of persons with disabilities. We have Ms. Lourdes Jack, representing the Palau Foreign Spouses Society, which supports expats married to Palauans, which is completely understandable. If my Palauan spouse needs support and he's Palauan as well, I can understand expats needing support as well. My apologies on behalf of my people. Last but not least, we have Mr. Rondi Rani, well-known radio personality, MC, and media tech, who is also the chairperson of LAIB organization, Palau's first and only LGBTQI rights advocacy resource organization. Thank you all for joining us this morning. We'll have a great variety of panelists, and I'm sure this will be a lively discussion. First off, I'd like to ask Mr. Masayos. I'm really embarrassed to admit that I'm not sure what the Council of Aging does. It should be indicative in the name, but I will be the first to admit that labels are not substance. Could you perhaps open our discussion by telling us a bit about your organization and what you'd like to see come out of this discussion? There's the microphone.
Oh, Ali, well, to talk more about nga Clarence, nga represent the Council of Aging. I give every state sa Palau, nga representative til mura council. Every woman til other council from each state na Palau. Tiya one elected nga makbu representative. So I'm here today on behalf of them. Itong ako are young people here. So I'm gonna be straight with you. One day you're gonna be like me. So I'm here today. Nga I'm retired. I came back home. Nga I'm more senior citizen. Oh, so I'm sorry. I'm talking Palis now. It's Palau in English, but she's telling me I need to go English. So please forgive me. Yeah. So I came retired back home, and I'm representing the old age people here. And we tried. What I wanted to talk about today is really how to help these people. How we help our elderly people here in Palau, how we can get programs from our government, from our partners from the Pacific Islands, see how we can help them, help programs. There's a few programs that we wanted to see done for our elderly, so that's what I'm going to cover today. So, okay, so since I'm here, I'm going to tell you about this. So our programs, we just held a symposium a couple of weeks ago, and we found out that, from the symposium that the aging population here in Palau is accelerating. We have to figure out how are we going to do this. Right on top of my head, we also found out that the woman lives longer than men in Palau. That's how, I found that out too. I'm new at this. I'm just active senior citizen not too long ago, so I'm still trying to find out. But what I've seen, my mom used to go to these programs. I learned some time ago that they have a really good program before we became independent, that the U.S. was supporting our programs. They call it Title V programs. They have all these programs for the elderly. I'm sure some of us remember the time when there was a lot of programs for the elderly. My mom used to come from Yuan. I'm from Yuan. They come to Koror. They have a lot of activities for the elderly here. going on in Koror. And back then, we didn't have a compact road. So they have to get on the boat and come here. So that's what I hear from our older people here, that we need to go back to those programs. So we're trying to figure out what's the best way that we can help our governments help us to support our elderly programs. We're not unique at this. The whole world, the aging population is growing now. So we need to figure out how we can help our people. And one of those things I want to mention today is from our symposium. We came up, we basically agreed that we need to integrate our programs with our cultural stuff. You know, we have culture here in Palau, so how we take care of our elderly, how we can change some of them, not the elderly, but some programs to fit today. Because today, right now, one of our concerns is like a home for elderly people. Because right now, you know, we're cash economy now. I'm sure everybody knows that. We're not sustainable economy anymore, so we have to work. So one of our, we find out, well, we know this, but it came out during the symposium, is how we can help that, how we can facilitate that with programs that we have today. Because most of our younger people now are both working. Mom and dad are working, and they leave their elderly back home. Somebody's got to take care of them. And then before, we have a lot of people around the house, our relatives, our cousins comes down around the house, so they can take care of our elderly. Well, not anymore. You know, as we all know, you know, everything is getting expensive now. People have to work. So most of the time, you know, we leave our elderly people at home while we go to work, not because we want to, but because we have to. And that's kind of what I want to tell these young people now, that you know, we need to think about that. Well, I know you guys are busy at school and everything, but you need to kind of see how you want to be when you grow up, and how you're going to take care of yourselves. I was the same way. I didn't even think about this, and now I'm home. Now I'm facing it now. How are we going to deal with this? So that's what I want to get out of this today. Just let everybody know, like, we had just had a symposium. They're still working on our aging policy. Our minister and their for health and everybody are working on that. We try to help them. We try to help them, you know, let them know what our issues are, what we're facing now. And I'm pretty sure most of us have experienced this before. We have our elderly at home, or you know, we know a cousin or somebody at home. So we kind of make sure that whatever we do, we integrate these with our cultural stuff. We don't really want to change that. I know Palau is, I just want to mention this real quick. Palau is, you know, we used to help, we have extended family, but not anymore. You know, I myself, my grandma used to live with us. And there's always somebody at the house. Now there's nobody at the house. I had to work. All my other siblings had to go to work. And then there's a culture thing about this. You know, in Palau, you know, we respect our elders. We listen to them. We listen to grandma, grandpa, everybody else. So we need to maintain that. And at the same time, how are we going to work to help the people here that needs help to take care of their parents?
So thank you for that. That's very interesting. Nobody told my parents that we're thinking of starting an old folks home. Let's
So
not do
can I mention something real quick? And then, so that's old age home. We need to consider that. That's just a fact, folks. We need to, how are we going to help these people to help them? And what's really surprising for me is I talked to some older people from the old age group. They seem to understand now that we do need to have a place for people to stay there.
Maybe you could hold some community outreach programs and talk to the elderly about those options.
Yeah, well, we are doing that, and the Ministry of Health is doing that, so we're helping out. But those are some of the things we need to consider now. It's noble, and then to help our older people, but we need to face the reality now. You know, so if you have an option, like you can keep your parents at home or your elderly people, good for you. But we need to consider those people that don't have any other choices but to help their folks. And that's what we're here for. So hopefully we can come up with something today. Thank you.
Thank you. That's a very interesting perspective of talking about the older populations and how we can help our older populations deal with the future. I'd like to switch and wonder about our children. Mr. Alexander, as a parent, especially as a parent of a person with disabilities and in your organization, how would you like to see our government cater services?
Thank you very much for giving us the opportunity. First of all, we appreciate the government for a number of things that it does to our children. But I think we need to first of all understand the vulnerability of the children with disabilities. The picture that Dr. Cuarte showed, there was a person, I guess, with a normal height. There were two other people, I guess one a little bit short and the other one very short. And it reflected the needs that we each have. The children with disabilities are born to parents who were not prepared to have a child like that. And we appreciate the government for stepping in when they go to school. Ministry of Education, Ministry of Justice are supportive with their programs, and they bring them to school, provide programs for them. They assist the parents in teaching, training, developing these children up until they graduate from high school. Once they graduate from high school, they send them back home. And there's no other government program beyond that. The parents have to take care of them until they, I guess, pass away, or the parents pass away. But there are a number of programs that the government provides that we are very grateful for. One of them is, of course, the Ministry of Education, embracing them as their children during the time that they're in school. We're not only grateful for the teachers and the people who are involved in their development in school, but also for the students who embrace them, take them as their friend, take them as their colleague, and they help build them up. And so we appreciate all that. But once they get out of high school, there's no other program that takes care of them. The government provides stipend for a number of people with disabilities, and we appreciate that. It helps purchase medicine, it helps buy fuel for transportation, in some cases food. Right now, we've been hit with PTSD, and that amount is not very helpful. But regardless, we are appreciative of that. We also appreciate the Ministry of Health for the number of programs that they provide. The Ministry of Health used to have a high-risk clinical services for those children. That's sort of dwindled down a little bit, so we ask that if they can pick that up again, would appreciate that. We also would appreciate, we see a number of challenges with transportation. During school time, they have transportation to school and back. But outside of school, the Ministry of Health provides transportation only during working hours. And when our children get sick outside of that, we have to transport them in our car, which is not equipped for our cars, which are not equipped for transporting children in wheelchair or children who are bedridden. So there's a number of challenges, and we know that the Ministry of Education, Ministry of Health and Social Services has a van, a couple of them. We ask that discussion take place between you and the parents so that we can help continue the services to the children during weekends and outside the working hours. Number of serious challenges that we face include, and we see a program with the Old Age Center where they provided a center for the old age people to gather, to share their stories, to share their experiences, and to grow together. It is also a way of achieving what Dr. Cuarte termed as wellness or happiness in life. It enabled the senior citizens to get engaged and get active again. The children with disabilities, once they get out of school, there's nothing else for them. And so we're hoping that with the help of the government and with the help of Ministry of Health and with the help of a number of other partners, we will be able to build a similar facility where children from Omgasang, disabled children, and even people who look at themselves that do not have disability but they want to get engaged and want to get involved with the children can get there and help the children continue their development. So it is a need that needs to be addressed because otherwise the children stop their development at 12th grade and then from there on they're a liability to the community. As parents, we have a number of other things that we want to do, and I think the most important thing is to partner with agencies that provide help to Omgasang to also embrace their parents and bring them into the discussion so that we can all work together to provide similar services to the same people that we are concerned with.
Very interesting programs, such as creating a facility, and I think interagency partnerships are very important. You mentioned Omgasang several times. In that case, I would like to engage Miss Cassandra Singero from Omgasang. Could you comment on several of the programs that Mr. Dwight Alexander mentioned, specifically about having a facility that would be a center for support programs and activities for persons with disabilities, and also on the programs that he mentioned for youth and education, and maybe talk a little bit about other programs that you would like to see for adults.
Malungit tutaw. Oy, agin madiscuss el girel el center Omgasang. Tambalas mlosi la center moriar ngalga morgamamri. Uk mare se iren marula wa bega. Malubut uk marul otro lere marula. Tatir go siga. Manda ko dek maseng wara trete lele lang. Nga ula katya nga so am sa experience nga sirak stroke. Imbigra mo adat yang. Akmla Miguel, 26 years, last year akmla stroke ang merbelaw. Akmara game rangalgaya ke stroke. A symptoms sa stroke, se sum kami sa amtalaat, el koram na mo melt. Mara del koram ambulance, la kamo mongi la kamo tamal. Makumis sa damran rangalgaya masem koram ambulance, ngiya se why? Kasi nga kan ba stroke. Hindi na rarang ulo may ambulance yung sa aramlal mora ospital. Mapuangan dia kasi ila choice tiril kut makla tamde sendra ka mora klol ospital am na helicopter. Makmong tasik sa toktang am di around ran kan balas mlo riolo bangke. Matak mo sila mo operate rap tulul makam da kasi ndiak. Hindi yung dik matang liarong ko nasi akong mga dado. Tulam da sek masenta kasi akong mga dado. O insi akan mga dado mak-remember ab tokol tokoy. Ila tigingir mora dambran algak maseng kada ka bolong dado. 3 days sa hospital makmigis. Alora mi kasi ko ngatel mga dado. Mas how? Say I don't know, I'm not a doctor, you tell me. Basta kita mga dado mo matigingil mora dambran algak maseng kada ka bolat. Madim na kumbarang. Hindi mo lang akal fight il girel. Hindi mo lang akal bigisin maral. Hindi mo lang akal enforce na akal bigisin maral al sila aplik. Which is, ako mes na 3 years old ang algay lang algay kal maral ulal. Makasas humangal ka sa reporter. Yang nga manda kasi akal maral. Makpigis o takla imal maging maral. Mangkam na orarang ulgalgay ka mamungol. Ngobde mo iglo o mga. Ngomang o ik. Makasinam ko mang oik. Why are you walking? Well, I have to. Hindi mo na kumarat tingin na toktang mula sa hindi mo kasi akan mutal mo maral, hindi mo kasi akan mutal mo mga dadu. Ak na refuse sa lombra. Tiya mading arakaw lahat. Asum kasom el mutal go back to your life. Tilgaw. Tigal migisel exercise arakaw. Lang mo marat tingin na on toktang arakaw. Hindi nga niya time hindi kasi ilmaskaw maklamral enser. Makner velaw nga materul nga ligek. Ngayon to help para nga, I go overthrow all my problems. Yung hospital velaw, takma therapy. Tidriyak murang masenda kasi akal maungil. Mangila sa arong urat Jason, makulumontay. Makasangara, employer kak muras, meron senda kasi maungil. Mamlaning aldado ulmorat tigay del lulurelo bangkek. Mingit sa senu telmedo sigarolel sendia. Ngobek refusal mo mandim lengak. Mga tangarab legal dingak. Dingak al maral, dingak al rukul to adi tal dakal ngeri nga arab linga praum tamdak taxes biap limam. Maknosmer emerbela obang kala dalak edokli. Hindi na kamner hindi na milo dem na stro, hindi na blastro. Makulban mo seltemel mosmer. Makmitut makasasum siya kamitut akut maklias meram rigel siya akut makliadalak. Makulit o si meringi malol beringi. Hindi na kamalabul tromes na sali hindi ako ulak karakaw ka modoklak. Makasi oy. Trinidad sa ki ospital yak na limam aktim ligi sa mesagingal padula sister adalak masyadalak ang lambosmer. Hindi na kumarang. Tiam hal di ngar ka at asum ka stroke, lam give up. Nga niya help sa mo may. Por hospital. Hindi ako kumarang nga radar apir belaw. Hindi ngila sa arong ukurat Jason, basta hindi ako klut telekong. Ang hospital belaw ngil. Elak compound. Alimlay malak. Hindi nga kami masingaral ka raw kulay. Hindi kasi kamabladra ka ro. Asum ka high blood, cholesterol, lang mo nga mayonnaise.
Thank you, Cassandra, for sharing your experience with us. Your strength is an inspiration. It's very important to remember not to focus on the vulnerabilities of people with disabilities, but to also focus on their strength. Sure.
Coming akti orang sera aldat ala Cassandra yung das kwase tokol otherwise yagi dali tatrit damreng asul la kabelment telpawel provide angye sulong sortir selpor hospital tokuni hospital digi mo mesaniya kasi ilal time ngaringi gel kora challenges ng ngara hospital al diakal cost by adloader hospital ay kang adamot ya hospital abli laser mangaringi tokorak termedidor alsel tira malbaan di lower and ki korol ngito sa selbo way tirga gidia ngaringi gel parking space niya lato del mortir lohel selbong yang masek tenabel parka roy del do wheelchair til maral mong agim langi tabla bulis girel say agidira kam langi tangya sul girela selbora gurulam etumang ebel di warbe class take time take long albebi that time ngaringi mo medal 2-3 hours aldi mo mesra toktang esel during that time period esel berrey etam lamde matret lamde marakta agi mesra bebira at selbong ilokora sugal tay blade ngaringi color code file tir yakoran mama kasengram de kalbolwaisen mortriga gidia al compromise the immune system tir mulsabaril mere dra gurulam makadukora am sub acceleration ng goradion mam kasi ngaringi gigil existing services al malungil memdi do meset improve the rule trigable mongil malbolungir away tirga gidal adult selabo elagal korang ngaringi abebira tukoy luturak leng mail mermay so just to say that there are existing programs and I think we applaud the work that the Ministry of Health is doing, and we give them support, and we ask that we continue to dialogue to make sure that they improve and get better. Thank you.
Thank you, Mr. Alexander. It's said that women care more about their communities than themselves. We take care of our children first before we think of ourselves. But we're here also to consider the needs of women. And in doing that, I would like to invite Ms. Hanang Ruulbaf to share a little bit about her visions and her thoughts on what programs are needed.
Ali malungil tutaw komrong sak. So ang also ko mo ra mulo check our sel website tertel sabit. Oo. Anyway, I was saying that if you were checking on the summit website, you wouldn't find my name and you wouldn't find all the other information about me because I did not submit. I was intentionally going to talk to Udol about declining to be on this panel, but 2 minutes talking to her, I couldn't, she made it so that I would feel so guilty if I didn't come here and speak. I'm finding this very challenging because I'm supposedly representing women's interest and I only have 5 minutes to talk. And so I've asked our facilitator to make sure to keep me on track with time. Otherwise, we'll be here until tomorrow. And so a little bit about myself. I'm retired. I'm a retired nurse. I worked for the ministry for a little over 30 years. And then I retired in 2013. So this month would mark the 10th year of my retirement. Anyway, I haven't been completely retired. I've been doing a lot of other sort of health-related stuff, some other community stuff. And so, you know, I've been thinking about what I would be saying. And I had a lot to say to the health people. I see the minister there and one of the directors there. And there's so much I would like to say, but there's so many students over here, so I'll be speaking this morning a little bit first to the students. So, kami ngal kala school ngaring kel pukor kami ura ka summit. Do we have your summit book? The one like this. Oh, they didn't get one? Oh, that's not very good. Because anyway, the topic of discussion is very important. It has 3 very important words. And the 3 words, one is equity, one is vulnerable populations, and the other one, sort of the first of that sentence, is talking about acceleration or accelerating. Yeah? I think do we agree that the accelerating part is talking about sort of the urgency, like we want to do things a little bit faster? Am I correct in saying that, Edon? Okay, she says yes. So, I think yesterday we also, Dr. Cuarte's presentation where he showed the 3 people standing on the stools, and we saw how it's not about just, I have $100, so the 5 people would get $20 each. Okay, that's equality. You each get your share in equal amount. Equity is a little different. Kami ulngal ka school. Kaso sa kuluteng wal mura reliable source. Ilkira lat tablol to ko erbelaw. Ngaringi kita other belaw I'm told ng kita bilong ngartang il tuta bilong. Oy. Kita other belam la apelwadam la exist for more than thousands of years. Okay? In all that time, our island couldn't have existed without any system of distributing resources. Haring at the Lord Tower Bella, two Palauan words that I had to call someone and really ask about their use and how and their applicability. How do they apply? And the two words are when someone bring a pile of fish over here, and we say to the village chief, okay, no, now how do we distribute this? Okay, so one way to say sngoselil. Yeah, I'm not going to attempt to translate sngoselil. Hindi kami ungal karpela un kakarel ngal kara school. Pomodengelo se say kita sngoselil is equality. If we have 15 houses, we distribute them equally to the 15 houses. Equity is looking at this pile of fish and deciding what kind of fish goes to this household because so and so are in that household. Yeah, so I tell you a little bit of personal story. I come from a village in the end of the road in Irai. If you're going toward the airport and instead of turning up to the airport, you go straight and you go all the way to the village. My village is called the Ordomala. That's the name of my village. And the old man who gets the job of deciding which, how am I doing time? This is a really, I really want you to hear my story because it's important for especially us young people in the room about how we divide things among people, how we divide health resources among the populations. That's the equity part. And then who are the vulnerable people? Who defines who they are? Okay? And do they know who they are? And so when the Rubak look at the fish, he said, okay, this Rubak in the village, I don't see the minister. It requires that the leader of that little community knows exactly how many households he has in his community, who lives in each household, and what vulnerabilities they have. Okay, so one house may have one widow woman who's looking after elderly parents and taking care of her young children. That woman would get a bigger fish so the kids will not swallow the bones and the older people can eat the meat better. But instead of just bring it like that, this Rupak or this old man would tell the young man, take this fish to the hotel. Kami ngal school kung dari hotel. Selwa lagi karel passion ngara bitarabli del boring emrulangi kali. So take the fish there and clean them up. And if it's a particular fish that the people like to eat the liver, and so to make sure you don't take out the liver because it's the fish that was caught at night. So I'm trying to make these little points because you may know the vulnerable people, but how do you deliver this resource to them? If you know who they are, do they like the way you deliver it to them? Is it acceptable to them? If you bring any fish that wasn't cleaned up to this woman, would you be giving her more work than what you're trying to do? So I'm trying to use this sort of maybe oversimplified way of explaining equitability and how it applies to the vulnerable people, and how do you deliver it to them, and in sort of a accelerated way so the fish don't spoil by the time you bring it to them. So there's another family where there's a young woman who just gave birth and she's breastfeeding. So the Rupak, they use select the fish that's good for soup because that woman needs to eat soup so they can breastfeed. Okay, that's understanding who is in the household. There's another house where one person walks by and mentioned the name, and the Rubak say, "Oh, so what fish would she like?" And someone says, "Buddha." Yeah, that's your assignment. You can go. You can go ask your parents to find the Buddha. I don't know. I don't even know the English name, so I can't tell you. But it's a good fish, and so the Rupak would say, "So put find some and put in their basket." And then they said, "Maybe you clean it." And one other person says, "Oh, don't remove the scales and the kasamdel, I don't gills." Yeah, because that's good. That's good. She likes it that way. So the point of this story is, again, the delivery and some compassion. And they sort of, toward the end of the day, I hear the women gossiping, and they say, I was wondering, why is this woman getting such special fish? And I hear the women gossiping. "Oh, ke tilo badararbay, abi ilamla o itia maray le mang lermel of the triarang alkel." Okay, I'm saying this in Palawan. Namo, am I over time? I'm almost finished. Okay, so the husband ran away and left the woman, and so she gets special attention, a little bit of compassion, a little bit of personal touch. Okay, so my challenge, and there's more, but I'm going to stop here because I'm really over time. I think the challenge at Edolm is, do we really know who are the vulnerable people? And are we reaching out to them in a sort of compassionate way? And this is the absolute last day, Lilay. There's a project that I'm still working with my colleagues, the First Lady Valerie and Annabelle. It's they're with the Coalition for Tobacco-Free Palau. And I didn't realize sort of the extent of addiction with tobacco. I honestly didn't, although I've been a nurse, I didn't realize how serious when a person is addicted to tobacco, and when you make them feel guilty all the time, that you already know it's bad for you and why you keep doing it, and they feel that they begin to avoid you. I'm very lucky. I haven't. I'm not addicted, but I have a lot of family members who are, and I'm, because I'm always making those. You're still using tobacco, and so I've had to really adjust my thinking in terms of, if you're reaching out to these vulnerable people, that compassion and understanding is very important. Addiction, whether it's tobacco or alcohol or whatnot, is a disease. It is an illness, and so it requires treatment. And so the part of that treatment has to be compassion and understanding. And if someone tried and failed, if you fall down, do you just stay there? No, you would stand up and take a deep breath and move on. So let's do that with tobacco addiction and other addictions. If you tried and you failed, don't stop, continue. And that takes a lot of us to be supportive. And I say this because I don't know who's going to come out in the community and say, enough about this, because we cannot afford to have oral cancer affecting our young people. I'm scared of the amount of oral cancer that I'm seeing. I won't go into that, but you know what the nightmare that I have is that we're going to be going through the community, and you'll see so many people who've gone through oral surgical well, surgeries, and we have a lot of people with disfigured faces and whatnot, and that's just not something we want to see in our community. And I stop there.
Thank you, Hannah. Thank you for your lessons. As both a nurse and a Palauan woman, you really have the world on your shoulders, which is why I'm very surprised about the statistics that Mr. Masayos quoted, that we live longer. I doubt it. As Hannah mentioned, our Palauan culture has unique systems for equity and the distribution of services. So in that, I would like to turn to the expat community and talk about that. Mr. Retamal, the Filipino community is the largest expat community in Palau. I'm sure there are second and third generation Filipino immigrants living here in Palau. Could you share a few challenges that you face in the services, the public services offered, and maybe talk a little bit about how you'd like to see it changed?
Hello, good morning to everyone. First and foremost, I would like to thank the Minister of Health for having us join the 2023 Palau Summit. Actually, I just sworn in last February 12. I'm just a newly elected president of the Filipino community in Palau. So, but as of my point of view, I think having affordable and adequate healthcare is beneficial to everyone. As an NGO, the TFCP, or the Filipino community in Palau, our aim is to promote camaraderie among us, and also we're trying to outreach also for the locals. For now, we have sports events, which is including the locals community also. We're trying to assist also the Filipino community in Palau for the healthcare, employment, personal growth, and other social matter. Throughout the years, we have several kababayans that needs medical assistance, and having the Palau National Hospital working alongside with the HCF, we have really helped us a lot. Many Filipinos have a better chance of living longer just because of this HCF. Those who had to seek medical services off island were also assisted by the government of Palau. Having small medical mission in the Filipino community have helped us to realize to take better care of themselves and ourselves. So being provided health equity benefits, even the smallest population for Filipino living here in Palau. Thank you very much.
Thank you, Mr. Retamal. Next, I would like to engage Ms. Lou Jack. As an expat married to a Palauan, you have a front row seat on both the stress of being a Palauan, married to a Palauan, and as being an expat living in Palau. Maybe you could discuss a little bit about the inequities that you do see in services offered to Palauans and non-Palauans, and as an expat, how do you deal with those?
Good morning, everyone. I am Maria Lourdes Calabia Jack, and I'm representing one of the vulnerable sectors in the community. The women. I am the president of the Palau Foreign Spouses Society, a group of women and Palauan spouses. One of the advocacies of the organization is to extend help in whatever way we can, in kind of goods, moral and financial supports, based on the capacity of the organization, or simply visiting people, showing affection, and care. Within my term, I was able to experience firsthand the effect of a very simple saying, health is wealth. Most of the assistance requests that we receive are seeking for financial assistance for patients who needs immediate medical attention off island, and I was invited to speak for this summit. I was caught on the topic, accelerating social protection programs to improve health equity for vulnerable population. Who are the vulnerable populations? Here in Palau, the vulnerable population include the children, the elderly, the socio-economic disadvantaged, those who can't afford to have a medical conditions, who are experiencing inadequate health care, no money, and worst of all, no family. All over the world, health gap is common issue, and this is because of the barriers set by the society. There are status classification which defines who can and who can't afford. It is impossible to experience a first-class healthcare without having a good job, good homes, or even just safety environment. We are supposed to bridge the gap. We are supposed to receive health equity. Everyone deserves to have opportunities to live the healthiest and to enjoy total well-being. Assessing the needs of people, I should say, health equity could be equivalent to providing lower cost of health care services. To those with lower incomes, I know all of us will agree on that. Health is wealth. This summit's topic calls for an urgent action for developing social protection programs to address social equity among all, as every one of us is vulnerable. And today we simply did one of the actions to promote this health equity by being given the representation, the chance to heard, and to be a part of the Ministry of Health and Human Resources program. I believe that health equities should mainly start from ourselves. We have the obligation to be healthy, to be educated and informed on any vital signs and factors influencing health. Elderly people and children should be represented. Evaluation of the family income and the assessment of the appropriate medical care each individual can afford. And search for assistance and opportunities for free access to health care. To each everyone, have a healthy day. Thank you.
Thank you for addressing income inequality. That's a very important factor to consider. I'd like to address the government sector. Ms. Akiwo, as the government actor and representing the Ministry of State, especially in the Bureau of Domestic Affairs, could you discuss some programs that you have reaching out to vulnerable populations, anything that's in the works, any plans moving forward?
Malungin sweldo to every and thank you, Alilay. Firstly, I want to thank Minister of Health for this very engaging summit and for inviting us to be a panel. So I had a presentation. Okay. So oh, okay, so the Ministry of State, under the Ministry of State, there's the Bureau of Domestic Affairs. In 2021, through Presidential Executive Order 452, the Bureau of the Division of Gender was transited to be one of the divisions under Bureau of Domestic Affairs. So within the Bureau of Domestic Affairs, there's the Division of Gender and a Division of State and Community Affairs. So for this presentation, I want to concentrate on the Division of Gender. So Palau has a gender mainstreaming policy. It was signed by President Remangsao back in 2018. And so for Division of Gender, that's the main core business, is to implement the Palau National Gender Mainstreaming Policy. And the policy is in place as Palau's commitment to create all necessary conditions to ensure all policies and services benefit all people at all levels of society. So men, women, boys, girls, from al-Seladil, from prenatal, and Monmora, end of life cycle. So yes, the gender policy, Rablu ensure say, like a framework for the government to ensure that. So the mission of the policy is to create all necessary conditions to ensure that our policy and services benefit women, men, and to take additional measures to remove barriers, gender equality, and safeguard human rights in order for Palau to achieve its sustainable goals. So, the goal of the policy, gender equality, so that all men, women, boys, girls enjoy fundamental human rights and have equal opportunities, especially to all services and products of the government, as well as responsibilities. We all have our own individual responsibilities and roles that we also have to play. Okay. So within the policy, prescribe institutional arrangement of implementing the national gender mainstreaming. It's very simple. It's a very short policy, very simple. It mandates to create, to create the gender mainstreaming interagency committee composed of all directors all directors of the national government to ensure gender mainstreaming gender policy at all sectors. And then provide advisory, monitoring, reporting, and lesson learned to improve existing policy and make sure they are gender streamlined. Oh, here. Gender streamlined, and that, yes, and there's a mechanism to, so it's a living policy to make sure future policy are mainstreamed at all levels of society. In addition to the interagency committee, it also mandates the Division of Gender to act as a secretariat to become the official government focal point for the gender and to provide coordinating and secretariat support to the interagency committee. So that's the whole Palau National Gender Mainstreaming Policy. And then at the moment, the Ministry of State, we are working with our internal government as well as our partners and donors. So we're at the moment trying to secure the proper capacities and OBs to provide coordination and secretariat support and Morsayidal interagency. Right now, we also have established dialogues with donors that have specific programs and global programs dealing with gender. So we've started on dialogues of how they can better support Palau and the Division of Gender to support the agencies and line ministries, civil society. We also work with civil society and partners and streamline our policy to make sure that equitable services and to all level our society and all our population. So as soon as we secure those resources, and then we're at the moment of reviewing TORs and talking to our partners in inter-office ministries, line ministries, on best way and mechanism to put the interagency together. That not just for the gender policy, but for other things as well, so that it's it's comprehensive, address all level of society. So that's my presentation for this today, and if any questions.
Thank you. Thank you, Ms. Agiwa, Director Agiwa. Gender equality is a current and sometimes volatile subject. Thank you for bringing that up and for helping Palau mainstream that gender mainstreaming policy. It's important to acknowledge, accept, and include all genders and identities in all policies, public policies of all countries, especially Palau. Mr. Randi Rani, as chairperson of the first LGBTQ organization, what policies or programs, public policies or programs, would you like to see in order to make health equity a realization for the LGBTQ community?
Check this. Okay. Malungit total mga other week. And when I was asked to come and speak about this, I was quite nervous because this is actually the first time we've ever talked about LGBTQ in public, in a public forum. So I would like to thank the Minister and the Ministry of Health for allowing us to use this as a platform to help the community of Palau understand. So when we talk about vulnerability, the definition of vulnerability is susceptible to harm, people that are easily targeted. And when you talk about LGBTQ, oh my goodness. I feel like I'm standing here in front of everybody after many years of vulnerability. And it has not been said until now. We've been pushed aside, we've been forgotten, we've been targeted, we've been called names. So when it comes to vulnerability in terms of the health sector, there are many downfalls. So I'm not here to call out anybody or anything, but it's about time that we talk about vulnerability at its core, at its root, and really identify the needs for everyone. When you talk about gender equality, it is the right to access medical help, medical treatment, it's the right to be identified correctly, so that way you can get the right access for health, for treatment, for any of that. It is the right to know who you are, so in school you can say they bullied me for this reason. So we can go ahead and argue about the cultural aspect to this. Malclo tutuloy sa cultural aspect. Yes, that is true. And we can go back and look at other things and find out other things, but that's not part of the argument today. I think most importantly is that as a vulnerable community, we have to have the right and the access to medical treatment. And I think the LGBTQ community has really organized itself and created an organization. And so the organization is called Laib. And if you have not seen the Laib bird, it is a rainbow bird. It is a beautiful Nicobar pigeon. Mukmedal wabalo nintel malako. Ooy. And so Laib stands for Living All Inclusive in Palau. And so the number one part of our priority is including people, inclusiveness. And so I almost argued with the minister the other day because I felt like it wasn't said in the program LGBTQIA, but I realized that this is really the initial start, and that I think Director MOS, yes, Eunice, Director Eunice can also see, and she's been working with us as well to really include us in some of those policies. We only see girls and boys, but there are others, but we can talk about that later. Yes, it is important that we identify the needs. Now, when we talk about needs, there are a lot of different aspects of needs, but I think one that I can mention now is the trans women and the trans men. So, number one, priority ko mama adra live, educate. Ling altakada mo kuvos ratoira culture and the silgot tel to tlela health ma safety ra other velaw. Ooy. Mang saya ko tel to tlela tora tel live lindal so mamal malangi dil syukang madakal so mamal malangi dil ngarang maldi so mamal educate ra at matumawla kadang dil gire la health ma mental health ma physical well-being other pelaro kuy most especially ang alka. So I think trans women and trans men are usually inside the LGBTQ community are the most vulnerable because they project themselves out there a little bit more than everyone else. And in the LGBTQ community, we call it you pass, when you can pass as a normal, straight person. But the trans community, they're out there, you know, they're being themselves, they're wearing whatever they want, you know. And so for Palau, at I think the very first thing that could be done from the government side is really address hormonal treatment. And I think that's an important issue that could be brought up and could be talked about because there are people that are thinking of transitioning from male to female and from female to male. And I think that's a conversation that we could start and really realize the safety of it because people who are not safe are taking pills that are not safe, are doing it in a very unsafe way, and could really risk their lives. So at the very least that the Ministry of Health can do is at least protect their safety and help them transition safely.
Thank you. Thank you for your courage. That concludes our panel. I realized that we went just a little bit over time. I would like to thank everyone for your patience and your listening. I would like to thank all of our panelists for a robust and fruitful conversation. I hope everyone here found it as enlightening as I did. To close, I would like to leave you with a quote from philosopher Thomas Reid. "The chain is only as strong as its weakest link. For if it fails, the chain fails, and the object that it has been holding up falls to the ground." We can't claim to be a successful, healthy society and nation without lifting up the most vulnerable among us. Thank you.
Thank you again, Alila, for facilitating this. Thank you to all our panelists. Please make your way. Sige, upstairs and say. Please be careful. Liab matim rakaw. Okay. So folks, like Alila said, we're running a little behind time, behind our schedule. Our folks, our next presenters in Hawaii are ready. So please, I apologize, we're not going to take a break. However, we will have Miley come give us some stretchings, lead us in some stretchings, just for a few minutes. and then we'll proceed with the rest of the schedule. Miley, please.
Testing. Everybody hear me? I can't hear you. Can everybody hear me? Okay, everybody's here, Ripka. So with me this morning is Ms. Ripka and Rushang, who are going to be assisting with our morning energizer. So let me give it to Ripka to start.
Leah, so I know we've been here for what, the past 2-3 days for some of us. Our brains are great. They're soaking in all this great information, and it's just growing and being all healthy. But let's not forget our physical health. There is no excuse, however old you are, young and old, we need to exercise, okay? So what we're gonna do is we're gonna give you a few simple exercises that you can do, especially when you're in school, you're sitting and you're getting tired, especially when you're in the office 8 hours a day. These are very simple, so there's really no excuse that you cannot do this. So Rushang is gonna instruct and I will model.
Okay, we're going to start from the bottom, so you're going to extend your leg out. Oh, please follow what she's doing. We'll start with the left, lift it a little bit off the floor, and then your ankles. Work your ankle to the left for 10 rounds, and then to the right for 10. Other direction, same leg, other direction. Now switch legs. And the other side. Okay, now your arms, raise your arms up. Keep your back straight, by the way, do not slouch. And down. As you're stretching your arms up this next time, inhale. And up, and hold. Exhale. Come on, let's do 3 more. And 1, and down, and in, and down. 1 more. And as you're seated, please twist to the left and hold. Twist to the right and hold. Center. Now your head. Hold your head to the left and count to 5. 4, 5. Other side.
1, 2, 3.
Now look left.
Left. And then
Right.
and then look right.
Around the world.
Around the world. Oh, not that around the world.
And last one is shoulders. Up and around. To the back. To the back. And 5 to the front. And the last one, please clap until you're 8. Thank you. I'll return the chair.
Okay, so thank you, Rushang, for that warm-up for the activity we're actually going to do. So we actually need 2 volunteers from PMA and 2 volunteers from Coror Elementary School. Oh wait, 3 from Coror Elementary School. So what they're going to do is, Ripka is going to, you're going to meet with Ripka, and then she's going to tell you what to do. But while they're meeting, I need everybody to reach stretch out your hands up to the sky, and back down, up again, and back down, and then stand up. Stand up, stand up, stand up, sit down, stand up, sit down, raise your hand again, stand up. Okay, Ripka, I think everybody's ready. I don't know if everybody got that, but you're gonna see it soon. So each rows and columns and aisles, you follow the student in front of you. So when whatever action they do, you follow, okay? So kids, you got your marks? We ready? Okay. So so everybody please stand, first row please stand up. Or column. Next. 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 Up, down. The wave is returning. Everybody knows how to, everybody's been to the ocean, right? You know what a wave looks like? It doesn't stop, it's always going. Go up and down, up and down. Hoppa! Okay, ready? That's a rip current. There you go. Up, up, up. When they go down, you go up.
Martina Richard, who is the president, Cancer Council of the Pacific Islands, and I believe she's also joined by our partners at the University of Hawaii, Dr. Neil Palatox and Jonas Baksa. Martina, whenever you're ready.
Thank you. Can you hear me, Sydney?
We can hear you.
Okay. Thank you, everyone. Ali, Mogatin, Kasalelia, Renanim, Lanwo, Yakwe, Hafidai, and Talofalava. Greetings, friends. My name is Martina Reichardt, and I am the president of the Cancer Council of the Pacific Islands, or CCPI, as we are commonly referred to. And for those of you who may not know or have heard about the CCPI, we're a Pacific regional cancer body that represents comprehensive cancer control programs in 6 USAPI jurisdictions, namely Palau, FSM, Guam, CNMI, RMI, and American Samoa. But before I continue on to my next slide, I would just like to pay my respects to the traditional and government leaders of Palau and the esteemed organizers of the Palau Health Summit, and also our distinguished presenters and guests that are joining us today. Next slide, please. So today our presentation will cover 5 broad areas and hopefully set the stage to get us all thinking about the definition of health and what factors determine individual and population health, and how these factors, commonly referred to as social determinants of health, are linked to health disparity and health equity. And I will also share a little with you all on cancer in the USAPI and the health disparities and potential for health equity as it relates to our work locally in each of the 6 jurisdictions and regionally across the USAPI. Next slide, please. So what is health? Health, according to the World Health Organization, is, and I quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. unquote. Some would say the current definition of health formulated by WHO is no longer adequate for dealing with the new challenges in healthcare systems. And despite many attempts to replace the WHO definition, no alternative definition has reached a wide level of consensus because it has many implications for practice, policy, and health services. Next slide, please. So when we talk about when we talk about health, we cannot ignore the role of social determinants of health. Research shows the social determinants of health impact more on individual and population health than actual health care itself. Where a person is born, lives, studies, works, worships, and plays all impact health and health outcomes. Some of these include, as you can see on the table above on the left-hand side, income, education, environment, personal behavior, genetics, gender, and of course, healthcare access. So when we improve the social determinants of health, then we can start to work towards equity, regardless of one's social, economic, and environmental status. Addressing the social determinants of health enables governments and communities to ensure that there are no barriers to health for our people as they journey through life, because what they need will be available, it will be acceptable, and it will be accessible and affordable. So when we look at the illustration here, where a community or society does not address the social determinants of health, such as access to education, healthy living environments, and healthcare, there are so many barriers. It's not easy for people to access the care they need and when they need it. However, if our governments and communities can address the social determinants of health by working together in public-private partnerships, so that regardless of a person's social, economic, and environmental status, they still have access to care when they need it. If we focus on having policies, systems, and environments that promote healthy behaviors and provide access to care at all levels, then we can focus on prevention, which really is so much healthier, cheaper, and sustainable in the long term. And it sets us on the path to health equity, rather than continually trying to find cures and undergo treatment. Next slide, please. In essence, I guess this is a key opportunity for preventing illness and injury by asking ourselves this question: what determines health? And if we look at this table here, we can see that healthy behaviors and environment make up 50 plus 20, that's 70% of the influence on one's health. And many researchers have also come to the same conclusion, that environmental and behavioral factors are more powerful influence on population health than genetics or access to medical care. So this is where our focus should be, on health behaviors and environmental. According to best available estimates, nearly 60% of premature deaths in the United States are attributable to environmental conditions, social circumstances, and behavioral choices that could be addressed through prevention. So each of us should ask ourselves and reflect in our own jurisdictions and lives, where is our focus currently? And where should it be if we are to start reducing health disparity and increase health equity in all we do? Next slide, please. Health disparity versus health equity. These two terms, disparity and equity, are usually used synonymously and interchangeably, but actually their definitions are quite different, and we should be clear on what they are when talking about health. So health disparity, according to the US government's Healthy People 2020 Health Initiative, is, and I quote, a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based on their race or ethnic group, religion, socioeconomic status, gender, age, or mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination and exclusion, unquote. And then on the other side of the spectrum, we have health equity. And the definition of health equity, according to the Centers for Medicaid and Medicaid Services, is defined as, quote, the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. So one, disparity basically refers to the obstacles or the barriers or the challenges or the differences that make it not possible to get optimal health. And then when we look at equity, it's almost like the effect. If we fix up the disparity, then we can work towards health equity. So we need to address the differences in risk and exposure. We need to address the differences in access to health care, and we need to address the differences in the quality of health care. So health disparities really are the metric used to measure progress toward achieving health equity. Next slide. So if we take a look at the per capita total expenditure on health slide here, you can see even just between the US API jurisdictions, there's a big difference in the total expenditure on health per capita in each of the jurisdictions. So when we look at the bottom bar, that's the United States spending on healthcare. They spend more than $10,000 per person. And then if we compare that to Palau, in the middle, just the three bars above, you spend less than a fifth of what the USA spends on healthcare per person, just over $1,700. And then Yap in the middle is even lower. We spend less than a third, of what Palau spends on healthcare, around $500 per year. And then we have Chuk at the bottom of the spectrum with half of what Yap spends, $228 on health per person. Next slide. And then this slide is another example of the disparity or the differences between screening and early detection for cancers in all of our jurisdictions. If you just look at the different jurisdictions, American Samoa, CNMI, Guam, FSM, Palau, and RMI, and then you look at all the different screening services that we have and the equipments that we have, you can see that our capacity and our ability is markedly different between each of the jurisdictions. There's no jurisdictions exactly the same in their capacity and their ability to provide screening and early detection services. And this data, the CPI, we collected it from our cancer programs in the region, and we usually update our data, and this is from 2022, to get an idea and better understand the broader context in which cancer prevention, screening, and care is delivered across these 6 jurisdictions. Next slide, please. And then when it comes to diagnosing cancer, again, just looking at this table, you can see the marked differences between the 6 jurisdictions in their ability and capacity to diagnose cancer in country. You will not find any of them exactly the same in all areas, except for maybe the fact that we all have a general surgeon in each of the jurisdictions. But when it comes to other specialties, not all of us have. And therefore, that also is another disparity in being able to diagnose cancer within our jurisdictions. Next slide. And this slide refers to medical referral and treatment for cancer patients in each of our jurisdictions. So if we look across the 6 jurisdictions on the first row, on-island chemotherapy, we can see Palau doesn't have any on-island chemotherapy, RMI doesn't have any either, and American Samoa, CNMI, and Guam have some semblance, mostly maintenance, but not actual on-island chemotherapy. And then we look at online radiation, the next row down. None of our jurisdictions, except for Guam, have online radiation therapy. And then we talk about referral off-island to different countries. All of us can refer to the Philippines, but American Samoa doesn't. And then if we look across, all of us can refer to Hawaii, except for Yap in the FSM. We're the only state that doesn't refer to Hawaii. And then we have off-island referrals to New Zealand or Taiwan, which Palau and RMI have, and Guam, but the rest of us, we don't. So again, you can just see this is just some of the differences in treatment and referral abilities in each of the jurisdictions. Yet we're all fighting for the same cause, a cancer-free Pacific. Next slide. So when we look at cancer in the US IPI and addressing health equity in cancer care, we should look at it from 2 fronts: individual health and population health. For individual health, as you can see on the left-hand side of your screen, those are all the things that we need to address and look at to achieve health equity and where we can start. And population health, as you can see, it includes addressing poverty, housing, food security, and access to physical activity, healthcare, educational achievement, and community clinical linkages to get patients into screening or back for further workup or treatment. And this is where our community health workers and community groups are critical to helping our programs to get towards this health equity that we're all striving for. And the NCD and cancer programs also in each of these jurisdictions, they work together and collaborate very closely and can help directly with addressing some of these. But the largest social determinants of health, such as poverty, housing, food, security, and education, they require a whole of government approach and a health in all policies. So for example, if you have finance and transportation ministries working on finance and tax policies, they should really work together with health ministries to discuss and better understand the impacts of those financial and tax policies on health. Next slide, please. Also, having health care and being able to access it is not enough. We should also make sure that that health care that we're accessing is quality care. And to have quality care in our cancer healthcare systems, we need to address all of the above that you can see they're bulleted in this slide. Patient health literacy, cancer screening and downstaging, lab and diagnostics, treatment modes, whether it's surgery, radiation, or medication, including chemotherapy, immunotherapy, hormonal therapy, pain management, palliative medications, and including providers. We need to have providers, provide quality care. They need to have their knowledge of medications, up to date, and the indications for cancer staging. They need to know about their national policies for referral and prognosis and the contraindications of the work that they're doing to treat their clients, and also what are the appropriate interventions, and be able to talk about side effects, combinations, palliative care, end-of-life care. Next slide, please. So this slide is the top 13 cancers in our USAPI jurisdictions combined. So if you're wondering, across all our 6 jurisdictions, the #1 cancer is breast cancer. And of course, as you can see in the male rate to female rate, more men are affected by cancer than women in all our jurisdictions combined. And then if you look at #7, that's cervical cancer. I think all our jurisdictions struggle with cervical cancer. And as you can see, it's #7 for us in the USIPA jurisdictions, but in the US, it's not even in the top 10, 20, top 30. It's like way, way below. But yet it's one of our top 10, #7 in fact. And so that's where HPV vaccination, primary prevention, all our jurisdictions are implementing HPV vaccination as primary prevention. And we also have cervical cancer screening and treatments for high-risk abnormalities. Some jurisdictions using VIA, most jurisdictions using PAP, and then now some of us are moving into the HPV primary DNA testing, which is becoming the new gold standard. And then we have liver cancer. That's also another issue for us in the islands. It's ranked at #6 across our 6 jurisdictions because hepatitis B, as you know, the vertical transmission from mother to baby, some 40 to 50 years ago was very wide. And in the outer islands, especially with infant vaccination rates being low, we still see vertical transmission today, mothers delivering babies and passing on hepatitis B to their newborn babies because they're not able to get access to vaccination, especially the jurisdictions that have outer islands, that don't have planes, that don't have ships that go there on a regular basis. And the single biggest risk for liver cancer, as we know, is chronic active hepatitis B. And we have that for many years. And that's why it's really important for us to make sure that we have good infant hepatitis B vaccination programs. They're critical to helping curb liver cancer problems down the road. Next slide, please. Now, when we look at adult cancers in the 6 USAPI jurisdictions, you can just pay attention to the red highlights. You will see in the second column there to your left, tobacco-related lung and oropharynx cancers, most especially in the anterior and mid-mouth are tobacco and betel nut related, and our tobacco-related cancers are high. So we need to continue reducing tobacco use, long exposures, and reduce obesity as well. If you look at our obesity column,
Martina, please unmute yourself.
Sorry, where did I stop off? So yeah, so back to the slide. If you just look at the red highlights in the table over there, yeah, we will see that in table 1, the tobacco-related lung, oropharynx cancers, most especially in the anterior and mouth, those are tobacco and betel nut related. And now tobacco-related cancers are very high, and we need to continue working to reduce tobacco use and lung exposures. Also, obesity is another issue within the Pacific Island jurisdictions that we need to address. And we also need to improve screening for our screenable cancers. And only then will we see eventual decreases in the high percentage of persons dead within 5 years of diagnosis. So if you look at the percentage of people who are dead within 5 years of having a cancer diagnosis, starting from Palau towards the midsection, they're going down. Most of us, when a person is diagnosed, 60% of them pass before 5 years is even up. Palau, Yap, Chuk, and Kashrai with the highest rate, 80% of their cancer cases diagnosed are dead within 5 years of their diagnosis. And so we need to improve on that. And tobacco, of course, is a preventable, tobacco-related cancers are preventable if we just reduce our consumption of betel nut or stop it altogether. So as you can see in the last column, if we go to tobacco, the oral cancers and pharyngeal cancers, you can see over there that half of the tobacco-related cases in FSM, for example, are due to betel nut, and more than half in CNMI, Pohnpei, and YAP. Or cancers. Next, please. Next slide, please. Hello, hello.
We can hear you. It might be a little bit slow to have the next slide.
Okay.
You should see advocacy.
Yeah, okay, thank you. So what has the CCPI been doing in the 6 Pacific Island jurisdictions to address some of these health disparities in our bid to pursue health equity? Well, some of our advocacy work over the years has included working and collaborating in churches and traditional houses. We also have worked with partners on the ground to look into banning the sales of single-stick cigarettes, and this is true for some of the FSM states. Also, most of our USAPI jurisdictions have implemented some form of tobacco taxing and using the money that's generated from the tobacco tax for prevention projects. Also, we have faith-based tobacco cessation programs in some of the jurisdictions, and Guam is focusing on e-cigarettes. And then we have betel nut chewing at government work sites being banned in Yap, Palau, and Pohnpei. And we also have healthier nutrition options being offered in terms of promoting more local foods, fruits and vegetables, and healthy vending machines and healthy menu options in some of the jurisdictions. And also worksite wellness programs such as physical activity and having only healthy food in the workplace, and also improving access to effective screening programs. Next slide, please. And this slide here, if you look at this diagram, it depicts the organizations and the programs that create the many partnerships to address cancer control in the U.S.-affiliated Pacific Islands. The Cancer Council of the Pacific Islands serve as the regional advisory board of the Pacific Cancer Coalition, and the CCC coordinators and chairs of each jurisdiction's comprehensive cancer control coalitions comprise the Pacific Cancer Coalition. So as you can see here, RMI, Palau, Guam, CNMI, and Samoa, FSM, represented by the 4 states. We make up the CCPI advisory board, and then we also work very closely with University of Hawaii and As you can see, we've mobilized many local resources over the years, and because of the tremendous disparities with locally available expertise in certain areas and funding and educational training programs and surveillance capacity, a regional CCC program and support structure was put in place way back in 2002. And so we've been going at it for about 20 years now. And the Pacific Regional Cancer Programs are actually administered by the Department of Family Medicine at the University of Hawaii, and they work synergistically with others in the university and other academic institutions and the U.S. National CCC Partnership and regional and international partners, as well as PHOA, the Pacific Islands Health Officers Association, which is our overarching advisory body for the CCPI. Next slide, please. And this is just a little bit of pictorial, so you can actually see who some of our founding members are and current members are today. As you can see from our humble beginnings in 2004, with our pioneers when the CCPI was first founded, the top picture on the right-hand side of your screen there, with a few members, and now almost 20 years later, we're a regional body of change makers working locally in each of our jurisdictions with commitment, passion, and caring to make a small difference, one step at a time, one day at a time, and one program at a time, one neighborhood at a time, along this continuum of cancer care, from prevention to screening, diagnosis, treatment, survivorship, and palliative care. And I'm really honored and humbled to be a part of this CCPI Ohana by virtue of my job description. And I get to work with so many talented, creative, skilled, survivor-centered advocates who go above and beyond creating public-private partnerships in their jurisdictions and opportunities and spaces for more community clinical linkages who are trying to help our people on this continuum of cancer care. And our motto really is, together we can make a difference. And I hope that the government and the people of beautiful Palau will continue to engage your cancer and NCD, diabetes, cardiovascular, tobacco, maternal child health, family planning, immunization, and behavioral health programs and your coalitions so that we can work together in partnership focusing on prevention as the way to addressing the social determinants of health in our pursuit for health equity, which we hope one day will lead to our collective vision of a cancer-free Pacific. Next slide, please. And with that, thank you everyone for your time and attention. The floor is now open. Questions. And I also have who are also our CCPI partners and very instrumental in their leadership and technical assistance in all we do as a Regional Pacific Cancer Body. And for those of you, if you're not sure, your Palau CCPI members are Ms. Adon Ikedo, Dr. Glenda Santos, and Ms. Irish Tuti. A great bunch of ladies. Thank you.
Thank you, Martina, for your presentation. Okay, moving on to our next topic. To give us a talk on the many forms of oral cancer is H. Charles McKelvey, DDS. He's a clinician, educator, and advisor at Twain Hart Family Dental Care. Mr. Charles, if you take the stage, please. Please.
Thank you, thank you. Should never start talking before you go up the stairs, just in case. Anyway, first of all, you're a great group of people. You've been here, many of you have been here all morning, and you're still here. And don't look at your watch, but we're running a little late, as maybe some of you know. Lunch will be waiting for us, so don't worry. So thank you for sticking around. Just a little bit about myself, and then there's actually more about me in the slideshow in just a second. But my involvement in Palau is brief, but fairly intense. I was part of a group of people that came in September for 2 weeks, Canvasback Missions, if you've heard of them. And we worked at the hospital dental clinic with my colleagues there, learning from them and getting to know them, and then sharing some ideas that we had. And subsequent to that, I was asked to return to give a few lectures here at your summit, which I think is amazing. And you're able to hear some very interesting information, some experts literally in the world as well. So what an opportunity. Now, this is a large group. The other lectures I'm giving are smaller venues, so it's a little harder for all of us in a large group. So I don't do audience participation, except one thing. I want to know, and you have to raise your hands so I can see them, who is younger than 21? Who's out there? Let's see your hands and keep them up. Oh, we have 2 packs of them. Okay, one over there. Hello. Yeah, thank you very much. You guys, I really want you to listen to this. Okay? Everybody else too, of course, but I really want to focus on those 2 groups as well. Let's begin, all right? So, Palau is not unique. You have oral cancer in this community. Every community, every city, every country in the world has oral cancer. Okay, and we'll talk a little bit more about that, and that's what I'm going to talk about today, is how oral cancer is affecting this community here. Now, I do need to give you my perspective. You know already I look a lot different than you do, okay? And not because I have a jacket on. So that's what I want to share a little bit to start our conversation, all right? First of all, I'm an American, German-Irish descent. I live in California, and I actually live up in the mountains in California, and our forecast for tonight and tomorrow is 3 feet of snow. So I'm glad I'm here, all right? If not, I'd be plowing and shoveling snow at home. I'm 60 years old. I've never used tobacco or drugs, and I rarely drink alcohol. So those are my habits, okay? And I think you need to understand that. Throughout my career, I've traveled to 16 countries to do dentistry. Part of my career, I enjoy going to other countries and helping, okay? So I've been around the world a little bit. And I've seen people in Yap, Cambodia, Thailand, India, Philippines, Vietnam, and Palau who chew betel nut. I've seen a lot of betel nut and the results of chewing betel nut. And I've pulled hundreds of teeth because of betel nut. Now, my perspective is medical, it's not cultural. And that's really important for us to start out this time together, okay? I'm telling you what I see outside of what your culture is, okay? People all over the world are dying needlessly from betel nut, from the cancer it causes. I know that because I've seen it. I've read about it, of course, as have you, but I've seen it in my chair with my gloves on. I've seen it, okay? But I'm here to present facts, and I hope some of these facts you'll listen to, okay? So let's talk about risks a little bit. Combination of betel nut, betel leaf, slake lime, often tobacco. The fourth most commonly consumed psychoactive substance behind alcohol, nicotine, and caffeine. Okay, there's 1 billion people in the world that chew betel nut. And we all know the results and the consequences of this. Now, I do want you to remember I do want you to remember that picture on the left, okay? When you or your friends are talking, you see a lot of the lower right picture of the stain on the teeth. But what I see when I have patients in my chair is what's on the left. Briefly, some betel nut statistics from Palau. This is from your country. These are a few years old. About half chew betel nut. Almost everybody chews it daily. Almost everybody has tobacco. I seem to be breaking up. Is that correct or not? The audio, is it good? Okay, okay. Smoking, and we'll talk about that. I have another lecture on smoking and betel nut tomorrow. Do you currently smoke? 83%, and 85% it's daily. So there's a lot of stuff going in your mouth besides food. Let's put it that way, okay? Right, there is some literature I want to share briefly with everybody. Let's just look at the yellow, okay? Betel nut is a tradition. There is a broad acceptance of betel nut chewing. And there was a study back in 2014. 30 Palauans were in Hawaii. And participants in this study showed little concern on the impact of betel nut chewing on their oral health. They continued the habit in spite of the awareness of potential for oral disease. Nurses faced challenges in educating Palauans about the negative aspects of betel nut, particularly those related to oral health, especially when they do not perceive problems. So, this is an important slide because this talks about what you can do. Upper left, 4 in 5 people do not know symptoms. Okay, so 80% of you out there don't really recognize what oral cancer symptoms are. That's pretty serious, right? This came out of the UK, 6,000 cases a year. You'll see some numbers out of the US and out of Palau as far as that goes. But on the right, these are the things you need to be looking at. Ulcers, patches, and lumps. Now remember that picture that we looked at earlier on the left that I mentioned? And you saw how damaged the cheek was on the inside? How are you going to see ulcers, patches, and lumps if what you've been chewing on has done that to your cheek? And you can feel that with your tongue. Here's some examples. And the arrows are pointing out what's going on there. These are examples of oral cancer. And if there's been a lot of betel nut in there, you can't detect it, and it's even hard for me or the other dentists in this community. A little more. Again, focusing on the yellow. Many as half the adults in Palau, Papua New Guinea, and the Solomon Islands chew betel nut either alone or with tobacco. It's classified as a group 1 carcinogen. Just so you know, group 1 is the worst. Smokeless tobacco used that's associated with cancers of the oral cavity, pancreas, and esophagus. Where this practice is common, have high rates of oral cancer. Where this practice is high rates of oral cancer. In Palau, 63% of middle school and 75% of high school students have chewed betel nut, and more than half of them in high school have chewed tobacco as well. Okay. Tobacco and betel is the perfect storm here. Can we change this out? Yeah. Let's see if this is better. Maybe up a little higher. All right. Oral cancer can present itself in many ways. Just 1 second here. Okay, we'll continue. Lip or mouth sore that doesn't heal. White or reddish patch on the inside of your mouth. Loose teeth. Now, loose teeth can be a result of gum disease, granted, but you don't know that, right? That's when you go into the dentist and say, hey, I have some loose teeth here. Will you do an oral cancer exam, or do I have gum disease? Growth or lump inside your mouth. Pain in your mouth, pain in your ear, difficulty or pain while swallowing, opening your mouth and chewing. Let me say something very important. If you were to come in to see me and there's a lesion on your tongue or under your tongue or on your cheek, I'll take a picture of it. I'll talk to you about, I'll get your health history. I'll talk to you about your habits. And if I'm not sure, I have you come back in 2 weeks. And any dentist in the audience does that, okay? If it's going to heal, it should heal in 2 weeks, okay? So if there's something in there that concerns you, give it a little bit of time. Think about what's been going on. If you bit your tongue, it's going to heal in 2 weeks, okay? (2016), I think this is our last one, or just about. Palau has alarming high rates of betel nut with tobacco. A significant increased risk for low birth weight among full-term infants was demonstrated among these women who chew betel nut with tobacco during pregnancy. Both betel nut with tobacco use and pre-pregnancy obesity were associated with higher risks of adverse birth outcomes. So, you know, this is not an auditorium full of dentists and doctors and nurses and so forth, where we talk about research all the time. But I'm showing you research so you know that the industry, medicine, dentistry, is taking this very, very seriously. We're doing the research, and therefore we're coming up with conclusions that we think have value, and you need to understand what we see and what we understand. So, 54,000 oral cancers a year in the U.S., 11,600 people die every year in the U.S., and the equivalent number, I've done the math, in your country will be 63 of your neighbors, of your family, of your friends that die every year. 63. I'm guessing that group right there. Next year, that's empty, and we have just this. And the following year, we lose this group, and so forth, okay? One more, I'm sorry. Serious health risk, carcinogen. We're going to talk about this oral submucous fibrosis. And I saw this when I was here in September, as well as other precancerous lesions. Strong connection between betel nut and increased risk of cardiovascular disease. Metabolic syndrome is a term that you may not have heard of before. It's kind of a basket. Obesity, high blood pressure, type 2 diabetes, and abnormal cholesterol and obesity, okay? You're unhealthy. Regular betel nut use may also lead to dependency and withdrawal. Again, this is research, these are facts, and it talks about the result. Okay, now you're at home, you've got something going on in your mouth and you want to learn more about it. We all have phones now that can take pictures. I have patients who take pictures of their mouth and send them to me. And you saw my my email, you saw my phone number, and it'll be at the end as well. And feel free to anything. You can talk to me, you can communicate, send me pictures, whatever. It's easy to learn from each other now, okay? Most of the oral cancer is in your cheek. We call the buccal mucosa. It's right here. You see a lot of it there, okay? The other is the anterior 2/3 of your tongue. You can see that by sticking your tongue out in the mirror. You can do a pretty good oral cancer exam at home. In another lecture I have tomorrow, I think, I have a little video that shows how one can do an oral cancer exam at home in the mirror. And then you can see the rest of the mouth. But those are the hot spots for oral cancer. And I have a little 5-minute video to show you. And we need audio on this.
It includes cancers of the lips, tongue, cheek, floor of the mouth, roof of the mouth, sinuses, and throat. Men face twice the risk of developing oral cancer as women, and men who are over age 50 face the greatest risk. While there are some risk factors you can't control, like your family history, there are some lifestyle changes you can make today. Here are 7 ways to reduce your risk of oral cancer. Number 1, quit smoking. If you smoke or chew tobacco, or use a pipe or a vape pen, try to quit or cut back. Smoking is the biggest risk factor when it comes to oral cancer. Your healthcare provider can talk to you about the best ways to stop smoking. Number 2, reduce your alcohol intake. If you drink excessive amounts of alcohol regularly, try drinking in moderation. It's recommended that men should have no more than 2 drinks each day, and that women have no more than 1 drink a day. Number 3, wear sunscreen. Protect your face and lips by using UVAB blocking sunscreen daily. Number 4, eat a well-balanced diet. A diet rich in fruits and vegetables is ideal. Limit how much red or processed meat you eat. You should also avoid fried or broiled foods. Number 5, schedule regular dental checkups. Your dentist will screen for oral cancer during your exam. It's also important to brush your teeth daily and practice good dental hygiene. Number 6, conduct a self-exam once a month. With a light and a mirror, look at your lips, mouth, cheeks, tongue, and gums. If you notice any changes, schedule an appointment with your dentist. Number 7, get vaccinated for human papillomavirus, HPV. The virus can infect your mouth and throat, causing throat cancer. Oral cancer can be scary, but if caught early, it is curable. Approximately 63% of people with oral cancer are alive 5 years after diagnosis. If you notice any symptoms or changes, don't wait to see a doctor. Early detection is key.
Okay. These are the 7 as a reminder. I've got to emphasize seeing a dentist regularly is really important here. Because we have bright lights, we have magnification, we know what we're looking for. It can make a huge difference. Okay. Is this our future? Kids? No. Right? Or this. Just real quick, sorry. On a side note, I got these pictures off the internet. Maybe some of you are here, or maybe that's your older sister, I don't know. But they're happy and their teeth are healthy, okay? All right, I don't know if anybody here has heard of this gentleman. He is apparently a very famous singer in Papua New Guinea, George Telek. And he had been chewing betel nut his whole life, or for his whole whatever, a long time. And they found oral cancer. And there's a lot of videos of this guy on YouTube, by the way. It's pretty good, actually. But this is pretty serious if you're a singer, to have oral cancer. We'll talk about in a few minutes what it looks like when we treat oral cancer. He was fortunate, and it's rare, that it was just on his lip. The surgery to remove it is much easier and not nearly as invasive if it's on your lip. And he vowed he was scared to chew ever again. If some of you in this room or your family or friends are considering it, the sooner you make that decision, the better. He won't chew anymore, he's scared, okay? So here's another picture of George in 2018. And this next picture is him last year. And you can see what they needed to remove. Part of his lip, part of his face. But he looks a lot older too, right? He's been through hell to have his oral cancer treated. All right. We're going to see some pictures of oral cancer. And I know a lot of these kids have never seen stuff like this before, and maybe a lot of you adults have not. This is stuff, I don't see it that often, but I'm aware of it. And by the way, before I forget, I was here for 2 weeks. I don't know if we saw 100 patients or something, maybe more. I saw more lesions that concerned me in 2 weeks here than I'd seen in the previous 20 years in my practice in California. It was the first day I was here, and a gentleman came in who was a chewer, and I thought, wow, first morning I'm here, and I see something that really concerns me, and we had a talk, of course. I says, oh, wow, right out of the chute, and then it happened that afternoon, and it happened the next day, and on and on and on. And the doc that came with me said the same thing. It was really concerning to us. Lower left picture, this gentleman here who was trying to open his mouth. So we're going to talk about oral submucosis fibrosis. Oral is your mouth, submucosis below the gum or below the tissue, below the surface. Fibrosis, something that's fibrous. Coconut is fibrous, okay? This is what can happen. And I saw this. I saw this in September. This gentleman came in and he could not open his mouth, but just a little bit. It's a pre-malignant condition. A third of these cases develop cancer. It cannot be cured. There isn't a pill I can give him. We can help him with some of the symptoms with exercises and so forth, get him eating better, perhaps. He has to stop the habit. In fact, I followed up in talking to the staff, and he's working on it to stop chewing. I did read, which I would never suggest, but sometimes I'll go in there surgically and try to, like a rake on a field or something, and open up the tissues or something to try to give him some opening. Some more pictures. And for some reason, we've discovered through research that some people react with OSF after just a brief encounter with betel nut. They start to tighten up. They can't open their mouth as far. You add tobacco in there, and it just kicks it up as far as the danger. Chief complaint is lockjaw. 20 millimeters is what? A little thicker than, probably about my thumb. He can't open his mouth beyond that. We can't cure this. All right, kids, look at these really carefully, okay? Because this happens. Tongue, the cheek, the throat, the palate. Big lump down there. There should not be a lump down there, okay? That's really serious. That person died. In fact, I would guess that's not even treatable, okay? The dentists in the crowd today know that we just can't clip that out with some scissors or a scalpel. That cancer goes deep. It goes into the bone. It goes into the muscles. It goes into the neck. He let this go way too long. There's no one, you can't survive this. You cannot survive that. I don't have a picture of what's inside his mouth. Now this gentleman, they did treat him. And his cancer may have been pretty small, but once they do all of the investigation and all the testing and so forth, they had to take out parts of both jaws, part of his face. These pictures bother me. Okay? This one on the left, his whole jaw is gone. They had to remove it. Same on the upper jaw. The one on the right, a lot of muscles had to be removed. Very debilitating, obviously. Now, I am going to breach this topic on traditional. Okay, remember, I've been to 7 countries. I haven't had this conversation in a public forum, but I've had this conversation everywhere I go where people chew betel nut. And I do respect your traditions. How could I not? But I think you need to look at any tradition in any country at any time in a perspective that some of them are harmful. Okay? I think we need to be honest about that. And I put some up here. Early child marriage. Okay? In fact, I'm going to Bangladesh later this year to work with a group, and their sole purpose is to take these girls, 12, 13, 14, and keep them in school. I'm going to be doing some oral exams and some fillings for them and so forth on these girls. Keep them in school, get them educated, so they're not married off, okay? That, I think we all agree here, is a harmful tradition. Female genital mutilation. That's still practiced throughout the world. I read there's 200 million girls that have been mutilated because of tradition. That's harmful. Child corporal punishment. None of us in this room beat our kids, right? Honor killing. This pops up in the news every once in a while. That's a tradition. It's not acceptable. So there are harmful traditions. Now, I had a conversation yesterday with a Palauan. He hasn't chewed betel nut for 20 years. And I was shaking his hand and congratulating him and so forth. He says, well, it took me about 10 years to quit. But he did say, I'm quoting him, this isn't me talking to you, stating that chewing betel nut is cultural is just a lazy excuse not to quit. So I have no business saying that to you. But he does because he's been there. And I think I need to share that in honesty with you. Okay? So, we're about done. My challenge to you, kids, I want you to listen to this. And I want you to take some of these thoughts home to your parents or grandparents. This is what I want. This is what I want you to do. You need to quit. You need to quit chewing betel nut and tobacco. Okay? Some of you are smiling at me. I can see you smiling. Okay? But you know what? This is half the equation. That's half of it. This is what Palau needs to do for you. They need to help you with resources of counseling, support groups, and partnership. Like I said, I've never used tobacco. I don't use alcohol, drugs, anything like that. That just hasn't been the way I grew up. Okay, but I have had friends who have suffered with alcoholism, and they struggle with tobacco, and they can't quit on their own. I know how many adults in here have heard of AA, a support group. And this is what the community needs to do to help those of you who are taking this talk seriously and reconsidering the habit that is possibly going to kill you, okay? You can't do it by yourself. So the community needs to step up. The government needs to step up. I heard a lot of good things today. I talked to the president yesterday. The community needs to step up and help the population to reconsider this habit. So in review, oral cancer is a real threat to Palauans due to the prevalence of beetle net. We can all prevent oral cancer. It can and has devastated families on this island. I think I've tried to make it clear that it can kill you. Oh, just real quick, that percentage of those that survive 5 years, there's so many percentages out there. I'm not sure what that slide said. But what's the flip side to those who survived 5 years? It's the ones that didn't survive 5 years, okay? And frankly, I don't care what the percentages are. If you're on the wrong side of that percentage, that's what's important. Why flip that coin, right? Cultural pressures must be overcome to preserve the next generation. And that's your legacy, adults. It's these two groups of kids right here. They're your legacy. You need to change your chewing habits as you prepare for the next generation. That's the honest truth. Thank you for your attention. Thank you for listening to me.
Thank you, Dr. McCovey. Thank you for your presentation.
Just real quick, I have another lecture in 20 minutes at another venue. It's across the street. I'm around through Friday. My contact information was up there. Do I go back or what? Or can you put that back up again? Okay. Oh, that's way better than me up there. Yeah. I'd be more than happy to have a conversation with anybody here. And I'll be around if you want to pull me aside as well. Okay? So, all right. Thank you very much.
Thank you. Thank you again. Okay, folks, we're a little behind our schedule. Lunch is ready to be served. It's at the back of these curtains. If you can grab lunch, I know we are behind schedule, so just reminding everybody that the afternoon outbreak sessions begin at 1 o'clock. Transportation will be out front and ready to shuttle people to those venues. Please grab lunch. Make sure you go to the breakout sessions at 1 o'clock. And make your way back here at 3 o'clock too. Thank you so much. Militasil, Milodaso. Good afternoon, everybody. Thank you for coming back. As soon as I find Delia, the girl with the raffle tickets, we can go ahead and draw a couple of them while we wait for the rest of the participants to come back from the other breakout venues. There.
Okay. Sulang. Hello. It's raffle tickets. Take out your raffle tickets. We're about to start. So the prices for today, there'll be backpacks, $20 cash giveaway, $50 cash giveaway, a tablet, and a mini speaker. Okay. Okay, so the first prize is a backpack. The lucky number is 546-7162. Going once, 546-7162. Do we have a winner? Yes. Okay, moving on to the next. It's also a backpack. The number is 546-6941. 6941. Going once, 6941. Going twice, 6941. Okay, next. Okay. Another giveaway is also a backpack. The number is 546-7082. 7082. Going once, 7082. Going twice, 7082. Backpack. Okay. Next, 546-7320. 7320. Going once, 7320. Going twice, 7320. Okay. The next number is 546-7168. 7168. Going once, 7168. Going twice, 7168. Okay, next. 546-6977. 6977. Hindi ah. Ngil abya.
Did you win?
Okay, good. Yes, okay. Ay, yata kami tayo hala kami pen. Namamra ka to. Okay, the next prize is also a backpack. The number is 546-7170. 7170. Going once, 7170. Going twice, 7170. Okay, next. 546-7376. 7376. Going once, 7376. Going twice, 7376. Nothing. Okay. Okay. 546-7013. 7013. Going once, 7013. Going twice, 7013. Okay, moving on. 5467045. 7045. Going once, 7045. 7045. Going twice, 7045. Okay. 5467268. 7268. Going once, 7268. Going twice, 7268. Okay, 5467415. 7415. 7415. Price is a backpack. 7415. Nothing. 5467362. 7362. Going once, 7362. Going twice, 7362. Nothing. 5467311. 7311. Going once, 7311. Going twice, 7311. Okay. Come on, where's the lucky number? Okay. 5467232. 7232. Going once, 7232. Going twice, 7232. Okay, moving on. Okay. 5467077. 7077. 7077. Going once, 7077. Okay.
Just go ahead and put the backpack with the $20.
$20.
And then those who want earlier, come back to me and I'll give them the $20 for the earlier, the one they want, because I don't want them to go back.
Oh, yeah, yeah, yeah.
And then
Okay.
we're going to change it a little bit further.
Okay. So, I'll include all the $20 with 4 backpacks.
Yeah, and those who want earlier,
Yeah.
come to me and I'll give them $20.
Okay. Do I announce?
Yeah, no.
Okay. So for those who won the first 2 tickets, you guys can go back to the MD station and get your $20. It was included with the backpack.
Backpack with the $20 now.
Okay, so the prices will be for the backpack. Will include the $20. Okay, so the price is 1 backpack and $20 with it. Okay, 5467400. 7400. Going once, going twice. 7400. Okay. One more. 5467074. 7074. Going once. 7074. Okay, one more ticket and we'll move to the next activity for today. 5467010. 7010. Going once, 7010. Going twice, 7010. Okay, save your tickets for the next raffle.
Thank you, Delia. It's unfortunate a lot of people didn't win. We're still waiting. We're still waiting for, I guess, some the participants from the other venues. I don't know, but keep your tickets. We may, if we have time later on today, we'll maybe draw a couple more tickets, and do save your tickets if you don't win today for tomorrow. Right now, I'd like to call on Miley and Ribka from the Behavioral Health Unit. They will be leading us in an activity this afternoon. Thank you.
Thank you, Mr. Gustav. Ali, everybody. Hello. So who here has a phone? I'm not going to steal it because I own a phone, so don't worry. All I can ask is if you have photos that you took for today, if you see the QR code on the back of the agenda, then please share it to the QR code. Other than that, thank you, and we're going to start our energizer. So cue the music. So the energizer is going to consist of directions. We came this far in life, so that means we know how to follow directions. So when I say hands up, we follow Ripka and Luciang, yeah? You follow what they're going to do, so hands up, and down. Clap. So when you clap 3 times, yeah? And then jump. If you can jump, you can just like stomp. I know we're not all able to jump. And please don't jump to the moon. So please, everybody stand up. What if they cannot live there? That's why just stop. Okay, so correction. If you cannot jump, just tippy toes. Tippy toes. Don't overexert yourself. If you cannot do it, it's fine. Just kick or do something. At least do something with your legs. So, music, please. We're going to practice. Up. Down. Jump. Clap. Down. And then this is secret action around the world. Woohoo! Yeah. Again, stop. Up. Down. Jump. Clap. Yeah, okay. So there's we're gonna do the opposite, okay? When I say jump, you clap. When I say up, you go down. When I say down, you go up. We get it right? So down. Up. Jump. Clap. Up. Down. Around the world. Counterclockwise if you want it clockwise. Okay. Okay, that's it. Okay. Everybody stop. And then raise your right hand. Put it to your left shoulder. And pat yourself. You guys did a good job.
All right, thank you, Miley and team, for that energizer. Okay, we'll go ahead and start with our next presenter. Paul Allwood is the Chief of the Lead Poisoning Prevention and Surveillance at the Centers for Disease Control and Prevention, CDC, and he's going to give us a talk on achieving equity in lead poisoning prevention at our environmental and policy making levels. Please make himself.
here in Palau. I've been sitting for a while and eagerly anticipating the opportunity to get up here and speak. And the minute I came up here and I was about to say, and everything. So, that just added to my excitement about being here. Let me first of all say that a little bit about myself. I am from Jamaica originally, so I'm from an island. But now I live in Minnesota in the USA, and I represent the CDC. And right now in Minnesota, I think you may have heard this morning, there's a big weather system moving across the US. And my wife told me this morning that we're expecting about 25 inches of snow where I live. So I have to do my best to pretend to her that I'm being treated really bad out here. And the weather is bad out here. The people are not friendly because she has to be doing all of the heavy lifting right now. So, but it's a real delight to be here. I got off the airplane at like 3 a.m. on Friday morning, and Delia was there with a sign waiting to welcome me. And then Chief Calvin also showed up to welcome me, and it was incredible. And as I got out of the airport, I said, "Oh, this feels like Jamaica." It was humid and it felt like Jamaica. And the chief said, "Welcome home," and that really, had a special feeling for me. So I felt like I've been at home, and I'm really excited to share with you, and I hope that everyone will find something of some little value in what I will share today. And hopefully there'll be time at the end for maybe one or two questions. So if you could move to the next slide, please. So what I'll cover today will just be giving an overview of the CDC lead poisoning prevention program. And then I'll talk a little bit about the epidemiology of childhood lead poisoning. Won't get too deep into it, but just so everyone can understand some of the basics of how lead poisoning happens. And then I'll talk about some of the prevention work that we're doing at the CDC. And then most importantly, we'll talk about partnerships, including partnerships that we're building with Palau and the other affiliated territories in the Pacific. And then we will talk about some resources, and hopefully we'll have time for one or two questions. If you can move to the next slide, please. So the goals of the CDC lead poisoning prevention program, and it's CDC lead poisoning prevention program, otherwise known as CLIP, the CDC CLIP, is to eliminate, to totally eradicate, and totally get rid of lead poisoning as a public health problem, right? And we believe that that's entirely doable. So please keep that in mind as I speak. And then our mission is to reduce blood lead levels in kids, and to eliminate differences in blood lead levels in different children based upon race or ethnicity or other types of superficial factors. Next slide, please. There are 4 key strategies that we're pursuing, and the first and probably most important is we're trying to increase the amount of testing that we do, right? And as I go on in this presentation, you'll see why it's important for us to be doing testing. And then we also want to make sure that our surveillance is really effective, that we're surveilling blood lead levels in kids, as perfectly as we can. And then we want to do targeted population-based interventions that would be aiming at primary prevention of lead poisoning. And you'll see later on why that's really important for us to do also. And then last but not least, we want to make sure that children that are tested and found to have lead in their blood are connected with services that can mitigate the harm from the exposure. Next slide, please. So I'm going to just jump right into a little bit of epidemiology, and if you could just skip over this one. Yeah, thank you. And I get this question a lot. Where does lead come from? And you can see on the screen that there are a number of sources of lead, and many of them are right within the household, right in the actual house that people live in. But there are sources like leaded gasoline that's still used in some parts of the world, particularly in piston engine aircrafts. There are the soil that's left over from the time that lead was used in automobile fuels, all over the world. There's drinking water. Lead can be found in drinking water from the plumbing and the lead-containing parts of the plumbing system. Children are also unique in that they can also be exposed to lead in a couple ways that nobody else can be exposed, and that's through breastfeeding, because mom's milk can also carry lead to the child, and also during fetal development, lead can be passed from the mom to the child. So I won't go over every single source, but just to kind of highlight a few of the big ones. Traditional medicines, can have lead. In the kitchen, you can find lead in spices. Lead can be in other types of foods. Lead can be in toys, in jewelry. Lead can be found in clothing. We recently had a recall where the ink that was used to paint a pattern on children's clothing was found to have very high levels of lead, and there had to be a recall on it. So it shows up everywhere. It's just one of those things, it's a material that has been widely used by humanity because it has some very useful purposes, and for a long time it was known that it was very hazardous, but for reasons that I don't fully understand, there was still strong pressure to use lead, and it's been used and used, and so it shows up in a lot of different places. Next slide, please. So there are two principal ways that children become exposed to lead, and the slide says by inhalation or by eating lead. And so small children especially, they're crawling around. There's lead dust in the homes from the decaying paint, or paint that has become, kind of pulverized into dust, like in windowsills. And so the child who's, the toddler, crawling around, or the infant crawling around, or the toddler who likes to play in the dirt can start breathing in some of that dust, and so will develop a blood lead level based upon that. Children, lead is also sweet. Lead has a sweet taste, and I don't know if many people know that. And so children will often pick up paint chips, and they put it in their mouths, and it's sweet, and so they eat it, and they get exposed to lead in that way. Children are also putting a lot of things in their mouths, as you know, toys, and and so those are the principal. But just to just keep that in mind, there are two ways that humans are exposed, either by eating the lead or by inhaling it. Next slide, please. I sort of touched on this already, so I won't spend too much time here. Basically, small children are at great risk for lead poisoning. Among the reasons, they have developing bodies, and their neurological systems are developing, and so they're much more susceptible to the harmful effects of lead. They're also mouthing things, and they're crawling around, so they can get it into their bodies a lot easier. And then also with children, more lead is absorbed, per unit body area than in adults, and so it's almost like a triple danger for children, and so this is why a lot of the focus and emphasis of the CDC program is on preventing lead exposure in kids. Next slide, please. So when children are exposed to lead, there are a number of different things that could happen. If there is a high level, or we can refer to that as an acute exposure, like for example, a child swallowed a trinket, and this is something that really happened not too long ago. The child, swallowed a trinket that was made out of lead, and after a period of time, there's very high levels of lead in the child's body. That could lead to death, and has led to death, or convulsions or coma, severe gastrointestinal symptoms. That's a very serious situation that, if it isn't managed very, very urgently, can lead to a very, very bad outcome for that child. However, we don't see that, and it's fortunate, we don't see that type of scenario very often nowadays in the United States. What we do see is low-level chronic exposure. So kids that are exposed to the lead from the dust, or the lead that's in a consumer product or a toy, and they're putting it in their mouths, and it's or the lead in the paint on the wall, The child is taking off bits of it and eating it, and the parents don't even really realize that that's happening. And so over time, the child is constantly exposed to a certain amount of lead in their bodies. That type of exposure leads to more subtle, sometimes no symptoms, but sometimes it ultimately, not sometimes, it always ultimately results in harm. Some of the harms that are associated with that low-level exposure include brain, nervous system, kidney, and blood systems effect, right? Including things like cognitive delays or slowed growth or slowed development, IQ loss, hyperactivity, and later in life delinquency, and even later in life chronic diseases like hypertension, heart disease, and so on are all associated with that chronic low-level exposure. So we have to prevent that. Next slide, please. So the summit is looking at health through the lens of equity, and lead is kind of the poster child for health inequity, because it's both the cause of health inequities, but it's also the result of health inequities. And so if you look at this picture of the world map, you'll see that in parts of the world where you have the deeper red colors, blood lead levels in children are significantly higher than the places that have the lighter colors. So if you can, this map will tell you, like in the United States, blood lead levels are, much lower than, say India, for example, if you can recognize India on the map there. And also, as we look at the part of the map that looks at the Micronesian region, you can see that the color there is getting pretty deep red. So there is concern. It's not equitably distributed across the world. Obviously, we don't want any child in any part of the world to have lead in their blood, but it is of concern that this continues to be a significant health inequity, that places in the world where the populations, there's high levels of poverty, there are also higher levels of lead in children's blood in those parts of the world. Next slide, please. So on the slide here, we're showing an image of a young child with a used lead acid battery. Globally, this is seen as one of the more important sources of lead exposure. Used car batteries have value. There's still value in them even when they're no longer able to power up a car. And so people all over the world, particularly in the developing world, will attempt to recycle some of the useful materials from the battery. This is done in the United States. About 95% of lead from car batteries is recycled. However, you have to have special facilities and special equipment to be able to do it safely, and it can be done safely. But unfortunately, in a lot of parts of the world where there aren't sufficient resources and equipment and facilities for safe lead acid battery recycling, it's still done, and it's done in an unsafe way. Sometimes it's done in homes or near schools or in other places where children can be exposed. And so that is a serious concern that we have to try to address as a community, as a world community of public health professionals. This is the only graph that I'll share in this presentation, and it's a really important graph. It was made by one of my colleagues at the CDC a year ago, and what it shows is the dramatic decrease in average blood lead levels in children in the United States, starting from the 1970s until somewhere in 2016. These data came out of the National Health and Nutrition Survey, which is a survey that has been going on continuously now for decades. And over every couple of years, there's a cycle of NHANES that was done. So, one thing I'd like to call your attention to is you can see that there's a pretty dramatic decline in levels from 1976 to 1980, shown on the x-axis to the far left. There's a dramatic drop-off, and then a more gradual decrease, until, at the end of this time period, 2011 to 2018. So you might just think of that, why was there such a sudden drop off in average blood lead levels in kids? Both kids 1 to 5 and kids 6 to 11. We'll talk about that in a few slides. Next slide, please. All right, so this health inequities in lead exposure, as I said, exists worldwide, but it also exists in the United States. And so despite the progress that we've made in reducing average blood lead levels, as you saw on the last slide, some children are at much greater risk for lead exposure than others. And those are kids who live in homes that were built before 1978, when the ban was put in place for lead in paint. Children who come from families that have lower household incomes are also at greater risk. Children who live in communities where housing values are lower than the average. Children who live in communities where there's higher population density. Children who live in communities where property values are depressed. And children who live in communities where there's a majority of minority, within the United States. So that is, still something that we are aware of in the United States, and I spend a lot of time thinking about how can we address that persistent problem of health inequity with lead, even though we are seeing success in reducing everybody's blood lead level over the last 40 years, but it's still unacceptable that there are some children that are bearing a disproportionate burden of lead exposures and consequences. You can just skip 2 slides, thank you. So I'm going to talk a little bit now about prevention. And the first thing that I would mention here, remember I told you on that graph you saw a really steep drop off in blood lead levels between 1976 to somewhere around 1985. And that's because of policy measures. Public health policy has been shown to be very effective in reducing children's exposure to lead. And some of the ones that are highlighted here, beginning in the 1970s, are removing hazardous amounts of lead from toys. It was a law that was passed in '73. The Safe Drinking Water Act was passed in '74. Banning lead from household paint, for consumer household paint, that was done in 1978. The Lead Contamination Control Act in '88. The Lead and Copper Rule, that's an EPA rule for drinking water systems, 1991. Banning lead from food cans, which happened in the mid-90s. And then, a big one was banning of lead in gasoline, which happened in '96. And last one on this list, and this is not an exhaustive list, was the establishment of the renovation, repair, and painting rule. So, this is just to make the point that with effective policy, we can actually win this battle, and we have to continue to look at that graph that says, yeah, we did see that big drop off. Things are kind of tapering off. There is still that disparity, there's still that inequity, and now we need to come up with other means to try to get to the point of elimination. Next slide, please. So millions of children are still exposed to lead in the United States, and adverse health effects and development effects are still being experienced. And we know that there are multiple sources. We already kind of talked about that. And then if you move to the next slide. So there are, 2 major approaches to preventing lead exposures. The first is, and most important, is that we want to primarily prevent lead exposures. In other words, we want to prevent children from getting exposed to lead in the first place, right? However, we're aware that, as we speak, there are already millions of children that have already been exposed. And so we also need a secondary prevention approach, which is based upon trying to identify kids that have already been exposed, and as quickly as we can, connect them to the services that are going to reduce the harm from the exposure. So those are the principal approaches that we are pursuing at the CDC. Some further examples of primary prevention. We can, remove the removal of lead from paint, which started in 1978. It's been a great thing, but there's still a lot of homes that were built before 1978 that have the lead paint. And so there have been efforts to try to mitigate that problem using various means to either stabilize the lead paint or in some cases remove it. And that has to be done very, very carefully. Things like cleaning floors and window frames and window sills and other surfaces can also be a way to execute primary prevention. Making sure that kids are washing their hands on a regular basis, especially after playing in the dirt. But not only that, but making sure that toys are being washed on a regular basis also, because those things can often end up in the child's mouth. If you're working outside in your yard, especially in areas that are known to have prior lead contamination, such as homes that are near major highways, then leaving your outside shoes outside and not tracking in that dust is also another effective way to execute primary prevention. If you live in an area where there is bare soil, there's no cover, no grass cover or any other type of cover, then you want to do something about that, because especially if you live in an area where there was high potential for lead contamination, like from automobiles, like from smelting or mining, then that lead dust could be blown around and could certainly get into the home and put yourself and your children at risk. All right, next slide, please. And then, so moving on to what I mentioned, which is secondary prevention. We know that there are already a lot of kids that have been exposed. According to UNICEF, something like 1 out of every 3 children in the entire world has lead in their blood. So that's something like 800 million children worldwide. So we know that their kids have already been exposed, and we want to identify them. We want to find who they are. We want to document the amount of lead they have in their blood. But most importantly, we want to connect them with services, treatment or support services that's going to reduce the harm. Again, most kids will not have any symptoms, or they won't show any sign, especially the kids that are exposed at low levels. You just won't know that it's there. You might suspect it if you know that there are lead-containing or lead sources in your home or in your vicinity of your home. But the best way to know if the child is exposed is to do a blood test. There are 2 ways to do this. One is a finger prick test, where a little bit of blood is taken up in a capillary tube, and that can be analyzed on a portable point-of-care instrument called the LeadCare-2 analyzer, or that can also be taken to a laboratory and analyzed on a more sophisticated method like an ICP mass spectroscopy or graphite furnace methods in a laboratory. Next slide, please. So the CDC has been interpreting and assigning meaning to different blood lead levels for a long period of time. And back in the 1990s, we were concerned with blood lead levels at or above 60 micrograms per deciliter. I mean, today that would be considered just absolutely, it would be, everything would stop now if we find a child with that blood lead level in the United States. That child would be receiving, emergency chelation therapy and other supportive services right away. But back in the 1990s, that was not so uncommon. And so back then, they didn't even have a way to describe that level. Moving on to the 1970s, if the level was at or above 40 micrograms per deciliter, that was considered to be an undue or increased lead absorption. So it was described back then. In 1975, similarly. By 1978, the levels of concern, in 1975, we began to be more concerned about levels at or above 30 micrograms per deciliter. But we still call that undue or increased lead absorption. By 1978, we began to say, no, if levels at or above 30 micrograms was an elevated blood lead level. And that continued in 1985. If the level was 25 micrograms per deciliter, we said, yeah, that's an elevated blood lead level. Moving on to 1991, we said, well, we got to lower this level even more. So now in 1991, if the level was greater than or equal to 10 micrograms per deciliter. We call that the level of concern. Level of concern. And then if in 2012, we created a new way to talk about children's blood lead level, and we call that the blood lead reference value, and we established that at 5 micrograms per deciliter. And what that is it's the 95th percentile of the blood lead distribution in children 1 to 5 in the United States. So we do that survey, the NHIN survey that I mentioned earlier, and then we calculated what the 95th percentile of that distribution of blood lead levels in those 1 to 5 year olds. And we say, all right, we're going to establish a level that's 2.5% of the population of those kids would be above that level, and we call that the reference value. Simply reason for doing that is that we want to make sure that kids who have higher levels of lead in their blood than most other kids, at 2.5%, are prioritized for follow-up actions, for additional testing, for medical intervention, and so on. So, so that started in 2012, 5. In 2021, we again lowered our level of interest to 3.5 micrograms per deciliter, and that's now the current blood lead reference value. It's 3.5 micrograms per deciliter. And so what we're saying now is if a child has a blood lead level that's at or above 3.5 micrograms per deciliter, that level has to be reported to the CDC as part of our routine surveillance, and that child has to be, and there's a set of guidance that we ask for the caregivers and the parents and the guardians to implement to ensure that that child is prioritized for additional follow-up. Next slide, please. So what kind of follow-up care is there? Well, it depends on the clinician's judgment, but follow-up care could include education, it could include monitoring the child's growth and development, it could include assessing the child's symptoms, taking a complete history, referring the family or the home for follow-up inspections by the environmental health team, to determine what the sources are. And there could also be medical treatment that is initiated at that point also. Next slide, please. We're going to actually skip over a couple of them because of time. So on to our partnerships. Right now, the CDC provides funding through cooperative agreements to just about all states and a number of local jurisdictions, cities or counties. And I won't read them all off, but all of the blue areas of the United States have current cooperative agreements with the CDC for lead poisoning prevention. And I'm really pleased to say that as of 2022, we are beginning to establish similar working relationships with other partners that are not on this map. So the state of Arkansas, the state of North Dakota, as you can see, those are currently not CDC-funded partners, but we're already in discussions with them to institute programs in those states. The next slide, please. We're also in active discussions with through our partners at NEHA and ASTO to create active partnerships and collaborations in the Pacific. And so part of my reason for being here was not only to come and meet Chief Calvin on the environmental health team, but to really have some deep discussions about what are some of the possible ways that we can build and establish a solid foundation for ongoing active collaboration in childhood lead poisoning prevention right here in Palau and other parts of the affiliated United States Pacific Islands. Next slide, please. So our website at CDC has a lot of information that would be very useful if you have an interest in learning more about childhood lead poisoning prevention, and if you're looking for specific guidance on how to handle situations that I understand happen here on a somewhat frequent basis, where a child has been discovered to have been exposed to lead, or lead has been found in a child's home, and so now something needs to happen, and it's not always clear what are the appropriate steps to take. I would say, get on our website and look at the materials that we have there. But even if that you don't have to stop there either. Chief Calvin knows that you can also pick up the phone or send me an email and let me know, I've got a situation here, we need some guidance. How can you help us? And we'll get on the phone. We'll stay up at night and make sure that we can have a conversation and come up with a plan for dealing with that case. We also have a new training package that we're just completing. It's a comprehensive training on lead poison prevention, and we are ready and willing to provide that training as a webinar. And so, if the chief lets me know that we can organize a training session, it doesn't have to be just with Palau. We could certainly try to coordinate that across the region a little more broadly, and that would be we'd be happy to do that. We're also working with our partners at MHHA, and Dr. Bliss, who's sitting in the front, has been a tremendous resource, and he's with MHHA in helping us prepare for a broader assessment across the Pacific Islands to get a better understanding of the current state of lead poisoning and lead exposures in the region, and also to help us develop a plan for how we might engage all stakeholders within the region, all of the environmental health program leads and other public health team members and decision makers in conversations about what needs to happen to develop active, systematic efforts to address childhood lead poisoning in the region. And then if I could go to my final slide, thank you. So this is just my way of just thanking everyone. I mean, obviously this kind of effort requires this kind of a meeting, and the planning and all the preparations that went into it reflects a deep commitment to advancing public health. And so I'd like to thank everybody that participated in planning, or who have spoken at the conference, or who are just attendees, because without the attendees, there's really no conference. And I'd also like to take the opportunity to extend gratitude to the people of Palau in general, because I have come and felt welcome, I felt at home, and without the people, there's no need for us to be public health practitioners. So my thanks to everyone, and if there's time for one or two questions, I'd be happy to do that, or otherwise my contact information will be in the summit booklet, and I'll be happy to be contacted by anyone with questions later.
Thank you again, Paul, for your presentation. Thank you. Thank you so much. Our next talk will be on expanding the culture continuum to indigenous culture as health. And this will be given to us by Professor Susan Helm. She's with the Department of Psychiatry, Jobson, University of Hawaii at Manoa. Susan, if you're there, we are ready for you. Whenever you're ready.
Given to us by Professor of Psychiatry, Jobson.
Can you give me screen share so I can do my slides? Okay, thank you.
So there we are ready for you, whenever you're ready.
All right, hopefully you can hear me and my colleague Cherry Amane. Simi, is our sound okay?
Given to us by Professor.
We can hear you okay.
Jobson.
Can you give me screen share so I can do my slides? Thank you.
So there we are ready for you, whenever you're ready.
All right, and my colleague Cherry Amane. Simi, is our sound okay? Thank you. I apologize for that. Not very good with technology, so I'll do my best. So my colleague Cherry and I want to thank you for inviting us to present on this topic. We are going to talk about Indigenous culture as health, which is an emerging model for nation states and other public and private institutions striving for health justice. I know that yesterday Dr. Cuarte had spoken, Senator Cuarte had spoken about health justice and wellness. So I think this presentation will go well with what he had presented yesterday. So the Indigenous culture as health model, we're going to describe it in the context of a continuum of culturally informed approaches with 2 examples from substance use prevention with Native Hawaiian youth and communities. And we're really honored to be here to present. So I recently retired from the Department of Psychiatry, and Cherry Yamane, whose background is in public health, she and I worked on these 2 projects together along with a bunch of other folks. Cherry is now a healthcare coordinator at the PADS Lake County in Illinois in the United States. So I'm going to talk a little bit about health justice and community-based participatory action research methods. Then I'll go on to share a little bit about the culture continuum from the perspective of evidence-based prevention science with the example from the Ho'oponopono Project. And then I'll pass it to Cherry, who's going to continue on with the Indigenous cultures health as part of that continuum. And then we'll give the example of the Punikula Plus program. And then we may have time for Q&A, but I think we're running a little bit late, so it's up to you folks how you want to handle that. For health justice and community-based participatory action research, I know this slide or something similar was shared earlier in the conference. So you're familiar with that first panel that shows people being treated equally. However, you can see the smaller person in that first panel can't see past that barrier. So that white picket fence represents a barrier to health. Whereas in the middle panel, each person is provided support specific to them. So now you can see that the person on the end has 3 stones to stand on, and they can see past that barrier. But with the third panel, you can see the barrier has been removed. And so when we're talking about removing that barrier, what we want to say is that we want to dismantle those sources of injustice. And I think the first 2, the being treated equally or equitably, have a focus on individuals, whereas the removing the barrier really is a structural approach. And I know there's been many ways of explaining that over the past 2 days and likely tomorrow as well. What I want to say about this is community-based participatory research, which is commonly used in a university setting, and community-based participatory action research, which is more frequently used with communities. Both of those approaches are going to rely on qualitative methodology. So I think James Ariola was talking about sharing stories and coming from our own perspectives. And so qualitative approaches are really important for looking at our own selves and bringing out the important aspects of our own lived experiences. Mixed methods also are important, so relying on the data, just like what Dr. Allwood had shared and other folks have been sharing more of the quantitative information. And then purposive sampling is also really important for these qualitative approaches. And by that, I mean asking people on purpose because they have something to say, that their story is important and relevant to removing that particular barrier, identifying what the barrier is and removing it. So health disparities is an important piece of that so that we know which people to be bringing into the health policy and health justice work. And so ultimately we have systems change to help remove these institutional and structural barriers. So going on to this expanding the culturally informed practices continuum, what I want to share here is that, as been pointed out by several people over the past 2 days, that much of the health interventions that we have rely on dominant cultural worldviews, and that worldview is implicit. And generally speaking, they're based on Western or Euro-American perspectives. And around the 1990s, people started rejecting that and saying that we needed to do cultural adaptation. And so there's many good examples of surface structure cultural adaptations in which the original intervention is retained, but some of the words and maybe the pictures might be different. So instead of saying family in Hawaii, we might talk about ohana, but it's still a Western approach to working with families. Culturally adapted programs at the deep structure are similar in that the original intervention is retained, but it's stripped down a little bit more and then built back up with many cultural assets. Cultural grounding refers to the idea that you're starting from scratch. So they are asking people what are their cultural assets and building an intervention from there. In these three examples, culture is identified, mined, and then transported into settings where this information can be used, such as a school for school-based programs, a health clinic or a hospital for more traditional Western medicine approaches. And if you're interested to read more, you can take a look at the article published in 2008 or Okamoto published in 2014. So I want to give an example of a culturally grounded program that we've conducted. And it's based on this evidence-based prevention science or the intervention research landscape, which is common in the US context. This graphic basically summarizes information that is published in prevention science. So I think of it as a ladder. So it's a 3-step ladder. The first step at the bottom is to establish efficacy, which means that the intervention has been rigorously tested under optimal conditions, meaning scientifically controlled. Once efficacy has been shown, including the long-term impacts, then you can move to effectiveness. And that's when you have positive outcomes, not only in optimally controlled situations, but in the real world. And once you've achieved effectiveness, then the idea would be to disseminate this information using materials for others to use with fidelity. And so that's what we did for the Ho'oponopono project. We used this pretty traditional NIH-style approach because the funding for developing the Ho'oponopono substance use prevention curriculum came from NIH. So this particular slide, if you look at the final column, it shows that we worked primarily with Native Hawaiian youth. So for the first study, the first set of studies, we actually had to develop the intervention. So that was even before stepping on that ladder. We had to figure out from a culturally grounded perspective, what do Native Hawaiian youth want to do in terms of substance use prevention? And so we asked kids, what are the situations in which you have encountered substance use and among kids about your age. So we're talking about middle school age children. We asked in the next study in a survey format, what are the more frequent and difficult situations? And then we developed a curriculum around that. There's more to it. If you have questions, I'm happy to answer later. And ultimately, what we created is a school-based prevention program. Scott Okamoto, who's now at the UH Cancer Center, was the PI, and I was the consortium PI on this, and Sherry worked on this as well. So what we created was a teacher training manual. It's video enhanced, and those videos show a drug offer, which are depicted in those photos to the right. And then there are 3 responses also video recorded. And then the teacher facilitates a pedagogy around critical conversation and skill building. So you can see these situations happen at school, like at the basketball court in the school's gym. It happens at the beach with kids that are about their own age. It happens with families. And then the middle, sorry about that. The middle picture shows 2 kids who have brought alcohol and Gatorade bottles, and the girl in the back is asking the teacher for some help. So these are all the situations that happen frequently but are difficult for kids to handle. And so then the teacher facilitates the learning in a school-based situation. I want to pass it to Cherry now to take it to the next step, which is the Indigenous culture as health.
So as we push along the cultural continuum of practices from dominant and culturally adapted, as well as culturally grounded worldviews, this moves beyond that with culture as intervention, in which culture is explicitly privileging Indigenous epistemologies, ontologies, and cosmologies, and harnessing the knowledges that was privileged and given to us by our ancestors and our elders. And so with this framework, Indigenous culture as health rests on these four modalities. So most cultural intervention programs that are developed extracts Indigenous ways of knowing, but often in the context of putting on like a Hawaiian word, for example, and saying this is a Hawaiian intervention. Whereas in this case, Indigenous ways of knowing privileges intergenerational knowledge that is either taught to us by our elders or respected cultural practitioners, and really harps on the values, customs, and beliefs that are instilled within us. But what pushes beyond that is the Indigenous cultural practices, by actually actively engaging within our cultural practices as like a way of being. It is a true way of being, specifically within a place-based or sacred site. So those place-based or sacred sites could either be within a fixed physical locale that is sacred and has been sacred for hundreds of years, or it can be a transitory space where we all come together, hui pu, and within that space, it is engaged with intentionality, and the value of that space shared with one another becomes sacred. And what encompasses all of that is Indigenous spirituality, as it is the foundation for everything, as far as like Indigenous ways of knowing, cultural practices, and place-based sacred sites. And so that model was developed through a systematized literature review from January 2012 to December 2017, which looked at these Indigenous populations who have been known to publish a lot on cultural interventions. And then we looked at culture and ways of knowing as it related to the levels of intervention. And from that systematized search strategy, we used a Prisma flowchart in which 908 articles were identified and windowed it down to 6 articles that met the criteria for actively engaging in cultural practices, and basically the implementation studies, like what does this actually look like when we're implementing an Indigenous culture as health. However, due to the limited scope of that, we included 6 more articles that were conceptual and in the development process that have not yet been implemented back into the literature review.
Thanks, Jerry. So one of the projects that we worked on, Cherry worked on this also, is called the Punikiola program, and it does fit the Indigenous culture as health model. So during the intervention development phase, the community wanted to have a Native Hawaiian approach to substance use prevention that would be acceptable in terms of using state or federal or philanthropic funding, because prior to that, the funders were saying you can't use your own intervention because it's not evidence-based. And so the community and I worked together with our team at the university to create this intervention. And another important component was to identify the youth as healers and leaders. And through the intervention development phase, which we had primarily qualitative using photo voice, the problem of historical cultural trauma and ongoing cultural loss and takings was identified as the main contributor for substance use that was to be handled in this program. And then with that, the solution would be cultural approaches, specifically the Lokahi triangle, which is depicted in the middle. So you have pilina or connections to your ohana or family, to your physical environment and the aina, as well as spirituality. And the idea of aloha aina is important, as well as promoting the idea of healers and leaders for oneself, their family, their peers, their community. So from there, we developed this program. If you look at the dark blue circle in the middle, it starts with an Ohana night. So the families are invited. Once they have identified that they want their child to participate, the families join and learn what the program is in more depth, and that is followed by a Haumana orientation and training. So the youth themselves are students in the program, and they learn a little bit more about what they will be doing across the program, which can run anywhere from 3 months to a year, depending on how many huaka'i and ho'ala. So the huaka'i, that translates to like a journey. And so they're going to culturally relevant places to learn about these sites from the person who is an expert. So the picture behind this is a fish pond, as an example, a local ia. And then they take pictures at that site, and then they have a ho'ala afterwards. So that's facilitated by a kumu or a teacher who guides them through what they learned at that site as it relates to their own well-being as a healer and leader, and regarding substance use prevention. So there's a series of these huaka'i and ho'ala that lead to a ho'ike, which is it's a way of making known to the community, or a community celebration, where the kids actually get to stand up and talk to the community as healers and leaders themselves. We do have a Punikiola Plus implementation guide. This will be posted pretty soon on the State of Hawaii Department of Health Alcohol and Drug Abuse Division website. We're making a few edits on this before it gets posted. And then in the course of implementing this program over the years, the idea not only is to do community outreach so that youth can be enrolled around the 4 eligibility criteria, which are Native Hawaiian kids living on the homestead, other Native Hawaiian youth, family members of the first 2, and then they also take referrals from community organizations. All of the kids participate in this Haumana advocacy, and this is the plus part, because in developing relationships with the Haumana, the staff realized that the kids needed more support, and they wanted to be able to provide that. So the staff includes not only a kumu who teaches the Punikiola prevention part of it, but a Haumana advocate who checks in with the kids regularly. And then they have this screening, brief intervention, and referral to treatment, so that kids are able to access the local adolescent treatment program for the kids who, based on the screening and voluntarily, would like to participate. I want to say thank you to our funders and to the homestead associations who've supported this. So the State of Hawaii Department of Health, Papa'ola Lokahi is the Native Hawaiian health care program in the United States. And Ahupua'a Molokai was a steward for Punikiola from 2015 to 2022. And Napu'olea Ohina is the current steward for this program. And I'll pass it to Cherry again.
And so again, with that being stated, when we're pushing along the Indigenous culture as health intervention continuum, like I said, it explicitly privileges cultural specific worldviews, and we're thinking about this in the context of intervention development, as opposed to, fitting ourselves and our cultures within a Western framework. What we really should be privileging is our Indigenous cultural sovereignty and our ancestors and our elders in this work, and especially like pushing beyond that when it comes to evidence-based practices, to push beyond evidence-based practices to practice-based evidence, and specifically towards community-driven evidence, where our knowledges, our data is sovereign and treated and cared for in that way. Yeah, and thank you. We're going to leave it open for any Q&As if anybody has any, but mahalo for inviting both Dr. Helm and I to present at this conference.
Thank you. We're very honored.
I want to thank you both for your presentations. Did anybody have any pressing question they want to ask them? Okay, doesn't look like there's any questions from our audience. Professor Susan, once again, we thank you both for your presentations. Thank you. Okay, ladies and gentlemen, we've concluded day 2 of our health summit. I need to make a couple of announcements. For tomorrow's morning plenary sessions, on your agenda, on your schedule, it says Father Hazel's presentation and Luis Venal Torres' presentations. The venue on your schedule says it's PCC, Palau Community College. That was an error on our part. Both those sessions will be here at the main hall, right here at the gym where we are now. Okay, so please make notes of those changes to the schedule. We want to take this opportunity to thank all our guest speakers today and all our presenters, and we especially thank you for staying with us for day 2 of our summit. We hope to see you bright and early again tomorrow. We want to remind everybody that we do have more great topics and speakers tomorrow. Reminder that registration is from 7:15 a.m. to 8:15 a.m. and then the program will day 3 will begin shortly after registration and breakfast. We do have breakfast for tomorrow morning. Please make time to come and do some networking while you enjoy a nice breakfast. Once again, we thank you for attending today. We hope to see you tomorrow. Have a good evening, folks. Thank you. Oh, one more reminder. Please complete and submit your evaluations. There are hard copies at the registration table. The online evaluation form should be up and ready at this time. So please complete and submit your evaluation forms. Thank you. Sound.